ले रहा हूँ। अभी ये केस हुआ कि जिसमें कि एक बेबी हुआ, अनुज का केस है, अनुज इधर है, हाँ इसी का केस था। उसके पेशेंट का एक बच्चा ख़त्म हो गया और उसको इथियोसिस या स्किन का स्केलिंग था, कुछ प्रॉब्लम था, बच्चा ख़त्म हो गया, बच्चे का ना डीएनए रखा ना कुछ रखा। अब वो केस इसके पास आया प्रेगनेंसी लेके, ये मेरे को बोला सर ये इसको ऐसा ऐसा था, क्या आप कुछ कर सकते हो? हमने बोला अंदाज से कर सकते हैं, जिससे स्किन का प्रॉब्लम होता है, वी विल डू प्रीनेटल और हस्बैंड वाइफ कैरियर। अब मज़ा ये आया कि वो बच्चे का जो टेस्ट किया उसमें ऑटोसोमल डोमिनेंट टाइप का एक डिजीज़ जो स्किन से रिलेटेड है, तो बच्चे को हो सकता है। तो हमने पीछे जाके मदर फादर का कराया, वो दोनों पॉजिटिव निकले और दोनों नॉर्मल है। अब ये जो एक्सप्रेशन है, ये जो चीज़ें हैं, ये अब आप क्या बोलोगे? 90% ऑफ द टाइम दैट द बेबी विल बी विदाउट डिजीज। अब जो मदर है बोली वो 10%, तो यहाँ फंस जाते हैं। तो इसके बाद आपकी इच्छा कि आपको रखना कि नहीं रखना, पर ये सामने रखा है, चूंकि आप दोनों नॉर्मल दिख रहे हो, आपको बीमारी नहीं है, तो ये बच्चे को भी नहीं होगी। तो बोले वो पिछला बच्चा उसको रहा होगा, ये उसका तो टेस्ट किया ही नहीं। हो सकता है कि ही हैड और शी हैड ए डिफरेंट डिसऑर्डर बिकॉज ऑफ दैट विच इज नॉट प्रेजेंट हियर, बिकॉज आपने तो उसको देखा ही नहीं। तो मेरा एक मैसेज हर बार देता हूं कि यदि किसी को स्टिल बर्थ या बेबी डाइज डिफिकल्ट है, उस समय जेनेटिक टेस्ट बोलना, वैसे ही दुखी रहते हैं आप, उसको 35,000 का एक टेस्ट और बोल दो, उसका डीएनए बोलो कि 5,000 रुपये लगेगा, डीएनए रखवा लो। जब मन ठंडा होगा, ठीक होगी, जब फिर से रिप्रोड्यूस करेगी, तब वो जब पूछेगी तब आप बोलोगे इसमें 20,000 का खर्चा आएगा, हम वो करके पहले देख लें फिर तुम्हारे बच्चे का करें। इफ यू प्रैक्टिस लाइक दिस यू विल बी, इट विल बी ए वेरी गुड वे ऑफ, आपको यदि डिलीवरी में बोलते हैं वो बच्चे का हम म्यूटिलेट नहीं होने देंगे, कान पीस ले लो, अपन बोल देते हैं कि आप थोड़ा सा ये ले, आप करके देखो, कॉर्ड रख लो, डीएनए निकाल लेंगे लैब वाले, वो रखा रहेगा। तो धीरे धीरे जो जेनेटिक्स का करते करते, मैं जो इतने सालों से कर रहा हूँ जेनेटिक्स का, जैसे पीपल हैव स्टार्टेड नाउ डूइंग, आई आस्क माय ऑल फेलोज दैट यदि वह सबके साथ होता है, स्टिल बर्थ होगा, सब होगा, डीएनए रखवा लो, ताकि अगला बच्चा जब हो तो आप ब्लाइंड ना रहो।
सर, may I ask one more question?
जल्दी बोल। हाँ
Sir, one patient delivered, all the ultrasounds were normal, no color Doppler anomalies, only the baby was having a small forehead. Cardiac echo was not done, but when the baby was delivered by cesarean section, baby had multiple cardiac anomalies. So now how to counsel the parents? Counseling, and also we don't have the DNA, the baby is still alive. But for the next this, how do we counsel the parents? And what all testing should be advised before conception?
I think one talk is there, red flags in ultrasound. When we see a small baby, most of us as obstetrician, immediately we fall to the default state that it is FGR, meaning it is placenta based starving, and therefore we look at that. That's not the way when it becomes fetal medicine. If it's small, it becomes a great red flag, and the question comes, why is it small? When we exclude all the other intrinsic problem, then only we assume it is placenta with evidence of placenta. In this case, obviously the smallness was the red flag, but I wouldn't say that that cardiac anomaly was missed. Some of them are detectable, many of them are not detectable. PDA, ASD, VSD, the commonest ones, bicuspid atrial, these are the commonest ones in general population. These are not detectable prenatally. And postnatally, you will see that multiple defects, PDA, small ASD, and then there is a bicuspid, but none of them are detectable ultrasound. So this one requires a genetic consultation, small with a heart disease. First thing is Noonan syndrome. Second thing is some Williams syndrome, and so many things are the little bit the uncommon syndrome, 22q microdeletion, Cyrus referring. So these syndromes we need to test by involving a geneticist.
I think he should, because थोड़ा लेट हो रहा है, start करें. You start your.
Okay, my slides, thank you. So now we are entering antenatal surveillance on a broader scale. We saw about fetal growth restriction, how to do the surveillance, monitoring and deliver. But in any woman who walks to your clinic for the antenatal visit, there are only 3 basic questions. When should I see her again? Should I or not give a steroid? When should I deliver her? Correct? These are the 3 questions that come to our mind when a lady walks to our clinic, and this forms the essence of antenatal surveillance. But antenatal surveillance is not the same for all babies, for all pregnancies, for all mothers. So it's different for different situations. We will see a handful of examples. Let's start with maternal autoimmune disease. How many of you have had the opportunity to treat an SLE mother? Yeah. The disease is common in the reproductive age group, and reproduction is common in the reproductive age group. So if you practice long enough, you will find both in the same patient. You should know. This is a 26-year-old priming, known case of SLE, already diagnosed, came for first trimester screening. Let the fetal part be there, but I want to know certain things in an SLE mother. There are many antibodies that may be present in her, but I am concerned about 3 antibodies as far as a fetal medicine is concerned, and as far as my fine-tuning of the surveillance. These are SSA and its cousin Rho 52 and SSB. I want to know in the first trimester itself, so we ordered that. It came back as strongly positive. SSA positive, its cousin, the other one is 52 kilodalton, also positive. So how do we counsel and what is the surveillance plan? When SSA and SSB antibodies are present in the mother, they go and seek their target. Usually it may or may not be there in the mother, but it will cross the placenta, and while searching in the fetus, they will not find the actual target, but the fetal heart antigens. The myocyte and the conduction system will express antigens which will closely mimic. So because of that mimicry, these antibodies will go like a targeted missile and attack them. If you don't have a previous attacked pregnancy, which is a primary or previous normal delivery, then the chance for this attack to happen and result in an attacked fetus, that is a complete heart block, is only about 2%, but you have to do the monitoring. But if an already attacked pregnancy has happened, then this chance jumps to 20%, now really at risk. What are the concerns in such a pregnancy? If the Rho, La, SSA is called Rho and SSB is called La, antibodies are present, it can initiate inflammation in the myocardium, but more importantly in the conduction system leading to heart block. It can also cause valve fibrosis, and a combination of this can cause cardiac failure or high drops. So this is an example of such case. In fetal medicine clinics, SLE is very common. Every other patient will come. So what is the fetal surveillance? So what is the antepartum surveillance for this category? You start the fetal surveillance at 18 weeks because we know the antibody has to cross the placenta. It won't cross by up to 16 weeks. Then it has to set up an inflammatory attack. So it will take 18 weeks. So you can start at 18 weeks. And how frequently should you monitor? Every 2 weeks. Not every week or every 4 weeks, every 2 weeks. But what should you monitor? Just the heart rate is not enough. Like in a ECG, we have a method to measure the PR interval in the fetus. So it's called MPR. M stands for mechanical. Because ECG is electrical, we don't get access to the electrical activity. So we do mechanical PR interval. And if everything goes well up to 28 weeks, you can say, okay, no more MPR surveillance required, then it becomes growth surveillance. The goals of antepartum surveillance in a SLE patient is primarily to optimize growth restriction. They are at 25% chance of growth restriction. But if they have SSA, SSB antibody, then another objective is to identify attack on the heart in the correct window where you can actually counter attack and prevent the heart block. All right. So in this case, at 18 weeks, we saw MPR 106 millisecond. Very happy. Go home. Come back after how many weeks? 2 weeks. But she came back after 4 weeks, 22 weeks, and already severe attack has happened. There's a bit of fluid around the heart. You can see fibrosis. You can see white stuff in the heart, and there is a complete heart block. Very severe, very fast attack. But still, we can act on this. We give dexamethasone to the mother, and then we prevent further deterioration of the myocardial function. We also start her on HCQ twice a day or once at night the moment she becomes pregnant with an SSA, SSB antibody, and these can prevent to some degree. If you identify it in the first degree heart block, that is only the MPR is prolonged, the PR interval is prolonged. If you identify at that stage, you give steroid, you can reverse a lot of these conditions. Then comes the goal in maternal tissue, connective tissue disorder is test for Rolo antibodies and do MPR surveillance. A slight difference from what we do routinely. So the difference is that. Now let's go to KUB. Part of it was covered by Shweta doctor, but let's see. This is a 21-weeker. You see there is mild bilateral pelvectasis. Of course, it will be reported because the radiologist wants to escalate it to a fetal medicine. You send to a fetal medicine, what are the concerns? We had this lecture before. It's a soft marker. It's a soft marker. So the first thing that we should do is what is the chance that it could represent Down syndrome? But the second is, can it be a marker of obstructive uropathy? When it is a mild pelvectasis, the chance that it will go into full-blown obstruction is only about 15%, right? So in the second trimester, we do an extended urosonography and importantly review her first trimester screening. Low risk for first trimester screening. Leave that part. We don't have to worry about it. Now for obstructive uropathy, we have to do the surveillance. The correct timing of obstructive next scanning is 28 weeks. Irrespective of our growth protocol, when to time the next scan. Now you have to call her back at 28 weeks just to know if this mild pelvectasis is going into a full-blown obstruction. By 28 weeks, most of them will resolve if they are benign conditions. 34 to 36 weeks, again we may have to see to determine whether to do a postnatal follow-up, and postnatally also we have to do the surveillance to know if it has fully regressed or requires treatment. So in this particular case, 29 weeks they came. You can see the pelvectasis has not worsened much, but if you see the coronal image, the calyces have got worsened. So it is now dilating within the kidney. That means there is a serious problem going on, and you see the bladder is thick and there is a dilated urethra. This is a case of PUV. Not all PUV will manifest in the 5th month itself. Some of them will come later, and the ones which come later have a good prognosis. That's a different story. So we need to surveil and find out that. That is only by follow-up, and correct follow-up we will get it. So when do we review? Another 2 weeks, another 4 weeks. Once you make a diagnosis of PUV, then the surveillance is, are the kidneys working? And in the fetus, we take that by looking at the liquor. Liquor is good, kidney is good. Keep following up. And when do you want to deliver? Term only. So you need at least 37 weeks. Get the lungs also fully matured, then you can deliver. And no change in the mode of delivery. You can see if she is a candidate for induction, go for induction and deliver vaginally. And the delivery has to happen in a setup where there is a pediatric cardiologist and the neonatologist. The neonatologist will stabilize, will draw the bloods, will do the basic workup, and the pediatric, sorry, no, I said cardiologist, it must be pediatric surgeon. Pediatric surgeon will then go ahead and do a valve ablation. Then the follow-up will start for the baby. So that's a different two. Long-term prognosis will depend upon the kidney and the bladder, right? So when you see a fetal urinary tract dilatation in the target scan, get a extended urosonography, follow up at 28 weeks, must. And then it keeps depending on what you find at 28 weeks. Let's move on to alloimmunization. How many of you have encountered and managed RH disease? Good. I hear that the prevalence is slightly higher as we go from south to north because the gene prevalence is also more. Now, this is 12 weeks, second gravida, previous baby, live birth, girl child, received anti-D. The failure rate of anti-D still exists. In the real world, it's not 2% like it is quoted in the textbook. Now she has come with ICT positive and the dilution is 1 in 8 positive. So, RH negative mother, if she shows an ICT positive, then the situation is called alloimmunized pregnancy. Now we need to have a protocol to follow this up. If it is the first alloimmunized pregnancy, that means no previous baby that showed jaundice, hydrops or died, and if you have good lab where they can tell you the titer clearly, follow up by the titer, 1 in 8 weight, repeat after 4 weeks, 1 in 8 weight, 1 in 8 weight. If it goes to 1 in 16, then you escalate it. But if your lab is not reliable, like the one I have in Pondicherry, we don't go by the lab. I have seen 1 in 8 baby in hydrops also. Totally unreliable labs. So in that case, or if already a previously affected child is born, say neonatal jaundice or even fetal hydrops, then titers don't matter. The moment you have a previous affected RH alloimmunized pregnancy, then straight you should look at the baby directly. And what do we look at the baby? We look at the MCA, PSV, middle cerebral arteries, peak systolic velocity. And this we start by 18 weeks. So the tool is MCA PSV, start is 18 weeks, frequency is every 2 weeks, and we intervene, we treat once it crosses 1.5 multiples of mom, or in other words, if the velocity in the middle cerebral artery is twice the gestational age. So at 20 weeks, if it's 40 centimeter per second, at 24 weeks, it's 50 centimeter per second. That means that baby is having severe anemia. We need to treat. All right? Right. So the crux is middle cerebral artery. So you should have very good skill to take the MCA, not just the skill but also meticulousness. So look at that. The interrogation line is coming like this. The middle cerebral artery is going in this way. Is okay if you want to do the PI, but not okay if you want to study the peak systolic velocity. You need to correct that so that the Doppler interrogation line and the MCA falls along the same line, 0 angle of insonation. Only then it becomes reliable. There are B mode signs, but our goal is not to let the baby go into hydrops, cardiac megaly, tricuspid regurgitation, placentamegaly, hepato. We don't want the baby to go into that level. All right. So once you see the crux is putting the needle into the umbilical vein, you can access the umbilical vein through the placenta at the base of the cord insertion. But my favorite is the last one shown on the far right, where the umbilical vein joins the portal system. So that's the place I put safest. Once you have transfused, then also surveillance is very important, not before you transfuse, but also after you transfuse. The issue is MCA PSV becomes less reliable because what we know about MCA PSV is for fetal RBCs, but we have transfused adult RBCs which have a different kinetics because they are shaped differently. And what we do follow up is, once we finish the transfusion, we know what is the hematocrit. Usually we will keep it around 45. And we know every day after transfusion, it will become 44, 43, 42, like that. One hematocrit fall per day. The next transfusion is when it reaches 25. So if I keep it at 45, in 20 days, I will be ready to transfuse. So this is the calculation they do. The surveillance is based on this only. You will still do every week MCA to identify one small subset that will undergo rapid hemolysis. Then what happens? We give every 3 weeks or 4 weeks transfusion. But the last transfusion, I will time it, adjust and time it at 34 to 35 weeks. This is very important. I don't want to deliver the fetus at 34 weeks who has received IUT, intrauterine transfusion, just because my NICU friend, neonatologist friend says, I can handle any neonate after 34 weeks. No, this is not that neonate. Because after birth, the problem is not jaundice, it's not prematurity at 34 weeks. No, it's the liver of a premature baby incapable of handling the bilirubin and the premature brain that is ready to get hit by the bilirubin. So we don't want that exposure. So 35 weeks we transfuse, take the baby, cross 37 weeks, the liver is now ready. That liver will handle the hemolysis bilirubin and that brain will be saved from bind, bilirubin-induced neurological damage. So delivery is at 37 to 38 weeks and mode of delivery vaginal is good enough, nothing to worry. So in an RH alloimmunized pregnancy, the surveillance depends on the history and transfusion depends on the MCA PSV. Now let's go to twins. What type of twins is it? Diamniotic. What about chorionicity? Monochorionic. It's very, very important that we tell chorionicity. That determines the surveillance. In a monochorionic, the surveillance should be with a fetal medicine division every 2 weeks starting from 16 weeks, and we are looking for growth, Leica, Doppler, 3 things. And if there is a discordance in the Leica, for example, one baby is having a lot of Leica, the other baby is having no Leica, then it becomes a TTTS in this case. Now, if no such thing happens, then important factors in the follow-up of monochorionic that will determine the outcome is what happens in the umbilical artery Doppler and what happens in the Leica. Every 1 week or 2 weeks, depending on the condition. If everything is fine, 2 weeks. If there is any discordance, you should shift to 1 week monitoring. And if there is a difference in the growth by more than 35%, or if the Doppler of one baby is so bad that it's going to die, or you see a stuck twin, that is Leica is so bad, or TTTS actually develops, then you must take some action. Those are the thresholds for action. I'll skip this. So in multifetal gestation, chorionicity. Don't take a report without chorionicity in the first trimester. Give it back. Tell me the chorionicity and then tell it's twins. Very important. 16 weeks umbilical and DV, 18 weeks add MCA, PSV. Thank you. Now, ventriculomegaly was already discussed, so I'm not going to go into that. I think Shweta madam discussed. Let's go to placenta. This also discussed, just a quick recap. We know the timing of the growth scan. This is a recap of the same thing. So in that particular case, we had to call her back at 26 weeks because she was hypertensive, she was type 2 DM and APLA positive. So high resistance, get her back in 1 week, by 28 weeks AEDF, but ductus was normal. So here, you don't give the steroid, you wait, do the DV, 31 weeks. So the surveillance tool in early FGR is always umbilical artery, we learned this before. Secondary tool is DV and CTG when it becomes, when the umbilical becomes AEDF, correct, okay. So We can skip this also. Last one. This is also quite common, you will encounter. This is a fourth gravida, para 1, live 1, previous section. At 20 weeks, she has come for second opinion for cystic lesion. So cystic lesion in the lung, you have to get a second opinion from fetal medicine. Most likely it would turn out to be what we call as a CPAM or previously CCAM. CPAM is congenital pulmonary airway malformation. You can see that. Now, in the evaluation of lung masses in the fetus, you need to know where the blood supply comes. Only from the pulmonary artery, good prognosis, most likely it will resolve. Also from the aorta, okay prognosis, most likely may not resolve also. Only from the aorta is a totally different disease, usually good but may require postnatal treatment. And you need to know if it is full of small cysts, so it appears like a solid tumor, or is it a big cyst. The big ones are notorious. They will secrete fluid and start expanding in the third trimester. And you need to know the size of the tumor with relation to the baby's head size. How many times the head size the tumor is. Up to 1.5 times the tumor won't cause any problem. So every 2 to 4 weekly we follow up. We follow up for the tumor size. We look for any chance of hydrops. In this particular case, at 27-28 weeks, the cyst started secreting too much and was causing hydrops. So we had to put a shunt. We'll talk about it later. And the baby was all good. So if you find a lung mass, then the prognosis depends upon the size, but you need to keep following it up. In the vast majority, at about 32 weeks, it will start shrinking on its own and should be a good outcome. Thank you.
Any questions?
I have unrelated question. Similar case, one patient operated by me, cesarean turf breach 2 years back, came to me without first trimester, combined screening, at 14 weeks, offered quadruple target scan. Quadruple marker came out to be positive. Offered amniocentesis. Amniocentesis came out to be negative for trisomies, but because CMA and everything else was done, the genetic analysis came out to be VOUS for one particular, which I don't remember. Now she's already 25-26 week across, because by the time they thought and underwent a target and the report came, now she's 26 weeks with VOUS with short interconceptional, not willing to continue.
Oh, okay. So even such as a genetic test which can produce a result not in the white, not in the black, but in the gray zone. That's the VOUS. We do a pre-test counseling and we document it that if it comes as VOUS, the chance of picking up a VOUS is about 10 to 20%. We would not act on that. That statement is given prior. Of all the viewers, 90% would be benign. Only 10% will be problematic. So while they come for a VOS, we analyze the VOS, we get in touch with the clinical geneticist. There is a database that we check, and once it's clear that it's benign, we tell them nothing to worry. Usually it involves testing the parents also. The parents may be carrying the same, and when they are normal, you can reassure them, nothing to worry. But in general, that information that we won't act on VOS should be given prior to the test.
Thank you. Sir, how do you follow skeletal dysplasia and congenital?
After termination, X-ray, get geneticist or pathologist opinion, then send the DNA for testing, usually whole exome sequencing. If the thorax is not narrow, it is a non-lethal skeletal dysplasia. If the parents are willing to continue accepting a small risk of dwarfism, then antenatally you can offer WES, that is whole exome sequencing. it would pick up some, it would exclude many, but not diagnose all. So this counseling again should be there. If they are not willing for amniocentesis, you follow up every 4 weeks to see if the growth velocity of the bones are maintained. If the baby keeps maintaining, in many of them you will see that it was a atypical manifestation of growth restriction that first manifested as short long bones. If not, after birth we have to deliver. This is for skeletal dysplasia.
Sir, where do you offer fetal autopsy as a must? Sorry, last question.
All defective babies and all unexplained stillbirths.
So now I will request for her topic on red flags in routine ultrasound.
Doing ultrasound, even if it is biometry, we should know what is normal, and any deviation from normal should be reported and referred timely. So this talk is not about making diagnosis, but to identify if there is anything which is not normal. And when the rule is, when we find one abnormality, we should look for other abnormality and see what is the diagnosis. So as Dr. Banerji told in the morning, that for obstetrician, the golden rule is to follow ISO guidelines, and we must know about the 20 planes that should be screened in any fetus. And if, only if we know what is normal, we can tell what is red flag. Any appearance which is not confirmed, it should not be broken as bad news to the patient unless we are sure. We should not do loose talking while we are scanning, because that creates a lot of anxiety, and one should refer to fetal medicine expert. So ISO tells to do 20+2 approach, which can exclude almost all fetal abnormalities. It is a combination of 2 overview sweeps and 20 planes. Each plane relates to a specific fetal section or view, and it has a checklist. Each plane has a checklist, what is normal and what is not normal. So when we put the probe, we should do an overview sweep, that is longitudinal head and body section for initial orientation, for situs, for liquor, for cardiac activity, for placenta. And then we do the fetal anatomy plane-wise. So when we are looking spine, we should see the spine in sagittal section, in coronal section, and along with coronal section of the spine, we should see the kidneys and arteries also. So likewise, we have 20 planes. I will be talking about each and red flag in each. So coming to spine, that is plane 1 to 3, we know it is, the normal is looking at the sagittal section and the coronal section. And if we know the checklist, what is normal, then we can pick up the red flags. We should see the continuity of the skin. Any break in the skin should be reported. That is abnormal. In the same section, we can see bladder, abdominal aorta, and we must see each vertebrae, whether it is regular or not. So in figure 1, we are seeing that the vertebra in upper part, we are seeing as regular, the skin continuity is maintained, but in the lower part, we are not seeing the sacrum. So even if we are not making the diagnosis in one go, we should refer this patient to fetal medicine expert with the finding that there is non-visualization of vertebrae in the lower part of the body. Even if we are doing this, we are doing a good job. Then any discontinuity in the skin or any bulge, we must see other anomalies which are associated with this and then refer. Again, if we are seeing this abnormality, we know that this is not normal. This is not following this. There is a bulge in the lower part of the spine, and even if we are not able to diagnose whether it is teratoma or meningomyelocele, we can write in our ultrasound that there is a mass with cystic area at the end of the spine, and then refer. This is the coronal section, which should show iliac crest, the sacrum, the vertebra, and the ribs. This is the coronal section of the lower part of the spine. And if there is any mass in this plane, again we can report that a solid lesion is seen of size so and so with few cystic areas likely to be teratoma, and then refer. Similarly, if there is a defect in the coronal section, again it points towards meningomyelocele. Next, 3 planes are for fetal head. The 3 planes which should be seen are transventricular plane, transthalamic plane, and transcerebellar plane. So this is the checklist for BPD plane. All of us are doing fetal biometry. We must ensure that we are seeing all these structures. Even if some anomalies are missed in target scan, if we are doing fetal biometry in 3rd trimester and we are finding any abnormality, we can report and tell it to the patient. So we must see cavum, septum, pellucidum, thalami, and the posterior lateral ventricle, and its width should be measured. Any deviation in this should be reported. In first figure, we know it is not looking like the normal one. What is the abnormality? We are not seeing 2 separate ventricles. It is a monoventricle, and in between the thalami are fused. So this is a case of holoprosencephaly. Even if we are not offering genetic test, we can refer the patient to fetal medicine expert for further counseling. In second figure, we are seeing dilated ventricles, and cavum is not seen because of the pressure of CSF. In third figure, there is a defect in the posterior part of the skull, and there is a cystic area behind the skull. So this is a case of encephalocele. Again, the rule is when we find one abnormality, we should look for other. We know there is associated Meckel-Gruber syndrome with encephalocele, so we should see the kidneys as well and see if there is any polydactyly. So if we know in which syndrome, which part is affected, we can also make a diagnosis. So if we find this image, or if we see this section on ultrasound, we know that the skull is not looking like a normal shape. It is flattened anteriorly. And if we see the same in transcerebellar plane, we will not see a dumbbell shape cerebellum. So again, when we are seeing one finding, we should look for other. If we see the spine of this baby, there will be a defect. This is how a transcerebellar plane should look like, a dumbbell-shaped cerebellum with vermis in midline, and CSP should also be seen in this plane also. So in first figure, we know that we are seeing a cerebellum. It should be measured, and we should see whether it is corresponding to gestational age or not, but there is a cystic space behind the cerebellum. So even if we are doing a scan and we see that this is not looking normal, even if we don't know that diagnosis, we should report that there is a cystic area behind the cerebellum and then refer the patient. In second figure, we are not seeing the vermis. The fourth ventricle is open and the cerebellum is small. So we have to document each finding, and then at last, if we can make the diagnosis of Dandy-Walker syndrome, we can write that there is a possibility of Dandy-Walker syndrome. So if we know that how a transcerebellar plane looks like, then only we can make the diagnosis of abnormal cerebellum. Next planes are for thorax. So plane 7 is 4-chamber view, which is very, very important, and it is not only to make diagnosis of congenital heart disease. We can see many more abnormalities in this view. 8th and 9th are LVOT and RVOT planes, and plane 10 is 3-vessel trachea view, which is also very important. So in 4-chamber view, apart from heart, we should start from periphery, and we should see the lining of the chest, whether it is continuous or not. The ribs, whether the length of the ribs is looking normal or not, the approximate area of the heart, whether it is covering 1/3 of the chest or more, and the area behind the heart. So what is the normal appearance or the checklist? The heart should cover approximately 1/3 of the chest. Both sides we should see the lungs. Left atrium is the closest to the spine and the most central structure. Tricuspid valve is more apical than mitral valve. Flap of foramen ovale is in the left atrium. Moderator band is in the right ventricle. This is how we identify the ventricles. And the crux is seen. Crux is the cross which we see at the junction of atria and ventricles. So in 4-chamber view only, we can detect many other abnormalities as well. Like in first figure, what will we report? The heart is pushed to one side, left or right depends on the situs. And there is a lesion which is occupying almost half of the thorax with multiple cystic areas. Even if we report like this and then refer, we are doing a good job instead of making a diagnosis there and then only. What is the diagnosis in second figure? Is there any abnormality? The continuity of the skin in front of heart is not there. So it is a case of ectopia cordis and it should be diagnosed in first trimester itself. The third figure is so minor abnormalities we can still miss, but if there is a gross discrepancy in the size of ventricle, it should be reported. Then if we are seeing a plus, we should see a continuity between the atria and the ventricle, and a plus looking area should be there at the center, which is called the crux. If it is missing, then it is a AVSD. So it should be reported, and AVSD is associated with aneuploidies and downs. The fetus should be further evaluated. In same 4-chamber view, heart might be normal, but we are seeing collection next to the heart. So again, we know that this is a red flag sign. It is not normal. Last figure, if we have to report this, even if we don't know the diagnosis, how will we say? The heart is pushed to one side of the chest. There are multiple, there is a cystic area next to the heart, which can be stomach, and the lung is pushed to one side posteriorly. So most likely it is CDH. So first we have to tell the red flag signs and then make a diagnosis. Plane 8 to 10 is for heart, for LVOT, RVOT and 3-vessel trachea view. So first figure, normally the aorta arises from left ventricle and it gets the blood supply from left ventricle. In second figure, we know that it is not looking normal as in figure 1. What is the abnormality? The aorta is getting blood from both the ventricles. This is called the overriding of aorta. Again, even if we are not making a diagnosis of TOF or other abnormality, we can just write there is overriding of aorta and then refer the patient. Crossing of great vessels is very important and we must see in third trimester also. In first figure, pulmonary artery is coming down, and in second LVOT, aorta is almost perpendicular to the pulmonary artery. So this is crossing over. They are perpendicular to each other. Third figure is showing parallel vessels. So there are many causes of parallel vessels, be it TGA or DORV. Again, if we don't know whether it is TGA or DORV, we can write that there is no crossing over of vessels seen. 3-vessel trachea view is important because the outflow tracts are there, and we should see that both outflow tracts are seen or not, and whether they are seen on left side of trachea or right side of trachea. Next is abdomen. What is normal? All of us who are doing fetal biometry, we must see to it that we are seeing this structure when we are measuring AC. It should be a complete circle. Umbilical vein should be seen, which is going away from spine, stomach bubble, and only one part of the rib should be seen, not multiple ribs. So we know what is normal. If we are seeing collection in front, it is ascites. If we are seeing two bubbles instead of one, it is duodenal atresia. Cord insertion is in plane 12, which must be documented. This is the normal plane. Cord is going into the abdomen without any bulge. And if there is a covering over the swelling and the vessels are going over the swelling, it is omphalocele. If cord is inserted on one side of the bulge, then it is gastrochysis and there will not be any membrane over it. The bowel will be freely floating. Next plane is transverse kidney and the coronal section of the body. This is for the kidney. One, it should be seen in transverse plane and another in coronal section. The pelvis should be seen as slit-like black lines. This is normal. Is this looking normal? No, it is not looking like slit-like, it is expanded. So first figure, we know it is pelvic testis, and if it is severe, we will see the callus, the dilated calyces also. Next plane is of pelvis, where we must document bladder, which is very important. The bladder should be seen along with the two umbilical vessels. So if the bladder is enlarged and there is also one more swelling, it is most likely PUV. Again, we should document the red flag sign that bladder is looking abnormally enlarged along with one more cystic swelling, most likely PUV. In second figure, we are seeing the umbilical vessels, but there is no cystic structure seen between the vessels. So bladder is not seen, liquor is normal, most likely it is excess trophy of bladder. Limbs are very important part of fetal survey. This is how a plane of femur lens should be seen. Both ends should be visible clearly and there should not be any spur. Distal femoral epiphysis, which is seen as a separate dot, should not be included in the measurement. And the angle of the femur should be 0 to 15 degree to horizontal. It should not be vertical or oblique. So we know it should be regular and it should correspond to gestational age. In first figure, we know that it is not looking straight. It is a bent femur. In second figure, there is a bulge over the in-between, which can be callus. In third figure, we are seeing one femur and second femur is not seen. So femur is absent. If we follow the ICO guidelines and we see all the planes, including the limbs, the chances of litigation is less. Sometimes we do the whole survey and we skip the limbs. So there are chances of many abnormalities getting missed. Upper limb, both upper and lower limb, the long bones should be counted and the movements of hands and feet should be observed. If there is a flexion deformity, both the hands or limbs will be in fixed position for a long time. This is the image showing CTEV. We know that the foot should be perpendicular to the long bones. If we are not seeing in this direction, it is a red flag. Next is face. How should face be seen? In coronal section, we should see the nostrils, upper lip, lower lip, and then chin. Any discontinuity, any deviation from this will give us a clue that there is a cleft lip. Then in coronal section, we can see the orbits. Approximately, we can see that we can fix one more eyeball in between two eyeballs. This is how subjectively we can see the distance and whether both orbits are present or not. Inside the orbit, we see a circular structure, lens. If it is opacified, like in third figure, it is congenital cataract. First two figures are normal, and the last figure is a red flag where we are seeing only one orbit, other is absent. The next is the facial profile. Again, it is very important. Face is like a mirror for the brain. So if we can identify facial abnormalities, we can have an indirect clue of many congenital nervous system abnormalities. So facial cleft palate, retrognathia, micrognathia can be picked if we have a proper facial profile section. These are the red flags in facial profile. The first figure, what is the abnormality? We are not seeing the mandible properly. So it is a case of microagnathia. In second figure, we are not seeing the nasal bone. And there is a mid-facial flattening. So we can keep the images of normal planes in our clinic and compare it with our images, and we can have a checklist and we can tick whatever we have done. So if we have seen all these structures in head, we can just tick this checklist with a pen that we are sure we have excluded most of the anomalies. Same way, for if we are doing a fetal echo, we can have a checklist and we can tick that we have seen all the structures in the heart. These are my references. Thank you.
Detailed and very interesting lecture. What about the panel discussion? Are we having it now?
Panel discussion, because Geeta, doctor, we will conduct the few cases and within 15 minutes we will finish it.
All right.
Who had 2 abortions, and she was referred to me with severe bradycardia, and the OT had to be ready and everything कि जल्दी से जैसे ही patient आएगी वैसे ही section करना है. But as I examined, she had 4 ultrasounds with her, full-term pregnancy, and then as I did the PV, it was such a gritty feeling, such a bad feeling. ऐसा लग रहा था कि पत्थर के ऊपर कुछ हाथ जा रहा है मेरा. It was a very bad feeling, and I told them that no, please don't ask me to do a section for this baby. But still they won't agree. फिर मैंने फिर से ultrasound के लिए भेजा. मतलब just 10 minutes before the delivery, an ultrasound done. The sonologist tell me go ahead with the section. The baby is all right. The fetal heart was 70 to 80. Still I came back and I said कि please don't ask me to do a section for this baby. उन्होंने शायद फिर मेरी बात मान ली. I delivered the baby and it was so horrible, crocodile skin baby, and मतलब like the baby was alive, everything was good, without a tail, but पूरा crocodile skin था baby का. And then फिर जब बाद में discussion हुआ तो it came out to be Herculean ichthyosis, and they said that these scales cannot be picked up on ultrasound. She had 5 ultrasounds. So only that feeling of 2, you know, when don't miss out the PV, you know, the rupture of membranes ho chuka tha. Only that feeling of that gritty feeling, it was, I mean, I can still, I mean, it was so bad that I can still get that feeling कि उस बच्चे का feeling कैसा था. And baby का सब feeding वगैरह सब normal था. The poor mother, because she did not have the earlier babies, continued with that baby for 1 month. Again, I counseled them, stop feeding the baby and let the baby go. And that scales cannot be picked up by ultrasound or what?
But we do diagnose them. Typically, the diagnosis is a bit later, not before 22-24 weeks. And there are some ultrasound signs like, because of the thick skin, the foot, when you see it in the coronal plane, will have incurling of the toes. And because of the shedding of the skin, there will be flaky amniotic fluid, and because the same defective adhesion is there, there will be exaggerated chorioamnion separation, and because of the thickening happening in the face, you will see ectropion, you will see eclabion, and the baby will have feature like this. So all these things to manifest, it takes time. So it's usually a late diagnosis. So if you have done a target early and then say, okay, we will do later, it's typically missed. In a case with the previous history, then it, you will start following up in the next pregnancy and all. But the best is to diagnose the genetic condition in that baby which was born. Even if the baby is going to die, I always say to the parents, let that baby give us something, some information, so that our future can be protected. So do the DNA, store the DNA, get all the signs and symptoms, do the genetic test, and then do a prenatal diagnosis or pre-implantation diagnosis.
Today. So I'll be continuing with the panel. I would like to invite all the panelists. Dr. Krishnan sir, he's already on the stage. Dr. Shweta Bhandari, Dr. Anuj Jain, Dr. Sonal Richaria, Dr. Pooja Wadhwani. Dr. Jigyasa could not join us today, so Dr. Archana Thakur and Dr. Anu Jain ma'am have in the last moment accepted to be a part of this panel. I would request them to come on the stage, please. So we will go about with the case scenarios and the questions, and in the end I would request our specialists Dr. Krishnan sir and Dr. Shweta to just give us a summary of the discussion. So we'll start with the first dilemma. So a 29-year-old primary patient at 12.2 weeks came for her first trimester screening. The nuchal translucency measures 3.3 millimeters. The nasal bone is visualized and there are no structural abnormalities. Her double marker shows low risk for trisomy 21, 1 in 1002, and trisomy 18, 1 in 4500. The CRL is 61. She is extremely anxious after the reading online that high NT indicates Down syndrome. So now what is the significance of borderline NT when it is combined with screening and when the screening is low risk? So Dr. Archana, ma'am, would you like to take up the question?
Ashita, actually, first you please show me the one question.
Yeah, sure. A 29-year-old primary gravida, 12.2 weeks, 12 weeks, 2 days. Her NT is 3.3 millimeters. Her nasal bone is visualized. There is no other abnormality. The double marker is also low risk for trisomy 21 and 18. And she is extremely anxious because the reading, she read online that this is a high NT and it indicates Down syndrome.
Okay. So for 3.3 mm and the CRL is, I think, 61 mm. So first I would like to see the centile. What is the centile? And then we'll put up in the whatever risk is there. So if it is low risk, then we may advise NIPT. But if it comes under high risk or intermediate risk as they report, so then I would go for invasive. And I would like to see structural heart disease also, because sometimes increased NT may be associated with Noonan syndrome.
Yes. So what was the...
That risk which was given 1 in 1002, that is based on double marker or a combined risk?
Combined risk.
That was a combined, okay.
So the question was that what is the significance of borderline NT when combined with screening? So borderline NT indicates mildly increased risk of chromosomal or structural abnormalities, but is often normal. So it requires individualized risk assessment in such patients, integrating maternal age, serum biochemistry and CRL. Now the second question was what would be the next step in management. As ma'am rightly said that we can offer her NIPT as a secondary screen, And if it is low risk, we can continue with a detailed anomaly scan and then consider early fetal echo for this patient. Now, the last question is, how would you counsel the patient regarding the prognosis of the baby? So, Dr. Anu Jain, would you like to take up this?
With the serial monitoring of the patient and her echo, her NIPT, we need to reassure her that there are maximum percentage that she would deliver a normal baby, though the risk of anomalous baby is also there. So we need to counsel her in that way and let the decision be on the part of the parents with the due risk, because we as obstetrician, according to our parameters, can always explain them the risk, but that let the decision be theirs.
So, Dr. Krishnan sir, would you like to comment on this?
Did you do the NIPT?
No, so that was just the case scenario. Like,
Yeah.
if we have a borderline case where the finding is neither saying high risk, neither it is saying low risk, then what to do with such a patient?
No, I agree with the previous discussion. In this case, in the first trimester itself, we will do a detailed ultrasound assessment. We will add ductus venosus, tricuspid registration, heart will be examined in detail. And between 3 and 3.5, we will go in and check the pedigree and have an overall assessment. As you had put it up, it's a customized assessment for that particular case. And then in most scenarios, we would also offer NIPT. And if the NIPT has come back as normal, we would reassure them, don't worry, and then come back for the target scan as usual. And in the target scan, we will do a full genetic sonogram, a detailed ultrasound, echo. If everything is okay in the target ultrasound, then it's a good outcome, nothing to worry.
Thank you, sir. So, in the next case scenario, a couple is referred for preconceptional counseling. Their first child, now 3 years old, is affected with beta thalassemia major, diagnosed at 10 months of age, and transfusion dependent. Hemoglobin electrophoresis revealed both parents are carriers. So the couple now wishes to conceive again and seeks guidance on safe pregnancy options to avoid recurrence. So what preconceptional options can prevent recurrence? So Dr. Pooja.
If the couple is carrier, like Dr. D'Pankar sir told us in detail, before conception we can give them an option of IVF and PGD and all, and we can counsel them and reassure them that it is like 100% detectable thing. By CVS also we can detect if they want to go with their own embryos and if they don't want to go with the PGD and all. So CVS is always an option in which we can 100% detect if the baby is affected or not. We can discuss the various options and then whatever the couple decide, we can proceed like.
Then what are the limitations of NIPT in case of hemoglobinopathies? Dr. Sonal?
NIPT is not recommended for hemoglobinopathies. It can detect aneuploidy very correctly, but not for the hemoglobinopathy. और आज सर ने सुबह ही बहुत अच्छे से पढ़ाया about the beta thalassemia, that is for preconception we should always go for a mutation characterization in the both partner before, और उसके बाद जिस तरह का म्यूटेशन है और जो बीटा थैलेसीमिया मेजर पेशेंट जो बेबी है उसमें जिस तरह का म्यूटेशन है, इफ़ वी कैन डिटेक्ट बोथ and then if we will do PGT, then we can easily diagnose about the affected baby and IVF implantation, that we can assure that patient a normal child for beta thalassemia.
If the prenatal testing confirms an affected fetus, then what are the management options? Dr. Anu?
Okay, so if it is confirmed, then for what we do is basically that first and foremost is the counseling part. You need to reassure, you need to counsel the parents that see, this is the condition, now we need to deal with it, and we should never forget the legal issues with this, because now we are in the era of all the medical legal things, so we need to tell them accordingly, and then we might give them the options, like if they continue, then the baby might need repeated blood transfusions. We need to give them the availability of the bone marrow transplantation, and whether they can avail that facility nearby their center, because we cannot give them an option where they cannot reach. So if they are in in which tier city they are, or they have the latest availability of an institutional care with them, so these options should be thoroughly discussed with them. Maybe this I would suggest, because we get lot of couple nowadays with the screening going on at national level for hemoglobinopathies, for sickle cell specifically in our Madhya Pradesh area. So now we are repeatedly getting the couples who are coming up with sickle cell disease, positive with beta thalassemias, HPCL, and our ICMR is thoroughly giving them the results. So with that, now our work has increased basically regarding the counseling, regarding the management options which we can give them, and we have to be very vigilant per se the medical legal part is concerned. And sir, I would request if you want to add some points to it.
Okay, generally in my setup they would end up terminating.
Yes. Next question. A 32-year woman, gravida for abortion 3, presents after 3 consecutive early miscarriages at 6 to 8 weeks. She has undergone extensive evaluation. Uterine cavity appears normal on hysteroscopy. Thyroid prolactin levels are within normal limits. Parental karyotypes are normal. APLA panel, lupus anticoagulant, anticardiolipin, beta-2 glycoprotein is negative. Her BMI is 24. She is not non-smoker. There is no history of diabetes. She reports emotional distress and insists on doing something extra to prevent other loss. So what further tests should we perform if there are any indications for further testing? So I would like Dr. Shweta to take up this question.
So in this particular patient, I believe we have tested almost everything, and about 50% cases of recurrent pregnancy loss remain as unidentified cause, such that we cannot attribute any particular reason to it. And for such unexplained losses, we obviously believe more of in counseling these couples to have a positive mindset, and tender love and care is what is suggested for these couples as per the RCOG guidance. There is no role of any other anticoagulants or anything else to be tested. Hereditary thrombophilias are not supposed to be tested. In fact, it's mainly the acquired thrombophilias which the patient has already been tested for. So I believe all the tests have been done. We should just give her, she just needs good counseling, preconceptional folic acid supplementation, and tender love and care. That's what is, I believe.
May I add something?
Yes, ma'am. Sure.
Male partner should also be tested for RPL. First of all, with the semen analysis, the other one is by watching everything about the morphology of sperms and everything, and DNA fragmentation index should be done for the male partner. Sometimes it is also responsible for recurrent bilited ovum in a patient, and only karyotyping is not a genetic test for RPL. You should go further more with the chromosomal microarray, with the genome sequencing, because karyotype only recognize the chromosome but not the genetic disorders or the antibodies which can be present in the blood, which is responsible for recurrent losses.
Yes, ma'am. So the next question is, what is the role of empirical low molecular weight therapy? Dr. Pooja?
I think it is not needed because APLA and all is tested, We can give good luteal phase support. That's it. LMWH, I don't think.
Yes. RCOG and SRA guidelines strongly discourage anticoagulation unless APLA positive or thrombophilia is confirmed. We are not supposed to give it.
When practically what we see, many of the gynecologists obstetricians are giving empirically LMWH. So God knows what happens.
Sir, what are your take on this?
Okay. Suppose in this lady I wouldn't give. Suppose she comes back after 6 embryonic losses and you have searched everything on earth, nothing is there. Would you give? So there is a concept called seronegative APLA, and some of the senior rheumatologists in South have been proponents of that concept, but we are not clear at which point it should be offered. And previously, that is in the era when it was floated around, it was heparin, not even low molecular weight. So that time we had to balance between hit versus a baby. But now that's not the concern. So as I would still agree that you should not take the heparin gun and shoot at everybody who had 2 losses, but it should have a place, and it does have a place in my empirical. I don't, RCOG yesterday, if you put, then I am a small this thing. So in my practice, if I would washed out every other option, empirical luteal phase support, no, and then comes the empirical seronegative APLA. I may be a bad person for the RCOG X-ray supporters, but if you lose 3 or 4 and 5, what else will you do?
Agree with sir, and there is, I think there are so many gynecologists over here who have this experience that with empirical low molecular weight heparin and ecosprin, we have good pregnancies up to 30. Outcomes are really good.
In vivo, heparin promotes trophoblast growth in vitro. So there may be some connection.
Yes, sir, definitely. So when a patient already has so many losses, we will try to use all the possible things we have in our basket, and we will try to give the best.
So the question that is unanswered is, what is so many losses? Is it 2, 3, 4, 5, 8? 8 also have
Depends
come.
on age, depends on the condition in which she is conceiving. Yes, marital status, age, and all the stress which she has.
So we'll take another case. So a 20-week anomaly scan, a 27-year-old woman's fetus shows an isolated echogenic bowel. All the other anatomical structures and growth parameters are normal. She had undergone NIPT earlier, which was low risk for common trisomies. There is no family history of cystic fibrosis, and the patient had mild spotting in early pregnancy. She is understandably concerned about the baby's prognosis and insists on another test just to be sure. So what is the differential diagnosis that must be considered in this case? So Dr. Anuj.
Do you have the image? Do you have the image? No. Echogenic bowel, mainly the chromosomal abnormalities are ruled out by all tests, and other DDs are for congenital infections and others.
Cystic fibrosis may be associated.
May also be there.
And most important thing which she gave in the history, that she has a early trimester spotting. Sometimes the blood which is there in the, it can be ingested, and because of that it seems, because she said isolated echogenic bowel.
Yes,
I think all the
isolated.
markers are normal.
Yes. So for this case, the differential diagnosis, like what all we should look for, it could be a normal variant, it could be an intraamniotic bleed, cystic fibrosis, and importantly, congenital CMV infection that needs to be checked, or it could be a sign of early FGR. So these are the things that we have to look for, not just aneuploidy. These are the different things that it can suggest and we need to look for in this patient. So what investigations will be indicated?
The first and foremost investigation is looking at that bowel, looking at that fetus. So when we get a second opinion, when the radiologist has seen echogenic bowel, it means it could be echogenicity in the peritoneum, it can be echogenicity of the wall of the bowel, it could be echogenic material, or it could be inspissated mucus. So anything can be there. And also what happens generally inside the abdomen, is there an inflammation going on, how is the liver? If you are thinking of congenital CMV, the blood enters the portal system first. First the liver is hit, then contiguously it will spread, then the peritoneum, the bowel, then the brain. So all these things have to be looked at. I will also look at the gallbladder to know if there is cystic fibrosis. Family history, anyway we don't have to know about it. It's quite common to think even without family history also. So all these things will give us a clue. It could still be a bowel obstruction. It could be a bowel obstruction that shows as a abnormal bowel, clumped up bowel. It could be congenital chloride diarrhea causing small cystic spaces. So many things are there. So the most important thing is looking at the fetus. After that we will decide in which line we have to go.
Yes, sir. So how should the follow-up be structured for this patient?
If nothing is there, and like madam told, if it's just blood that is being swallowed, you will see it intraluminal echogenic things, nicely moving bowel, peritoneum is clean, liver is clean, baby growing very well. We just reassure, tell them to come back after 4 weeks. That's all we do. But if any suspicion is there, then we go full bound. We put the needle, take amniotic fluid, we send it for torch PCR, CMA, whole exome sequencing to cover the CFTR gene also. So everything will be done.
I had a case with echogenic bowel.
Fetal signs only. We don't do otherwise. The fetus has to show sign. For example, in this case, if there is liver calcification, spleen calcification, peritoneal calcification, or in the brain if we see excess echogenicity, then we will do a torch PCR.
I had a case referred with echogenic bowel. Later it turned out to be a case of skeletal dysplasia. So on thorough examination, the ratios were coming abnormal. Then, so it is like presentation of other genetic diseases also.
Once I had a CNS, septal agenesis, referred as echogenic bowels. Unless those features which I just told are there, it's not recommended.
So I think we'll be done here. So thank you all the panelists, and thank you Krishnan sir and Shweta ma'am for their insight on these topics.
Please sir, one question, Krishnan sir. Autism, previous baby with an autistic disorder. Now they want what to do next.
If it's a male baby, we will go ahead and test the child for Fragile X syndrome. There is a 1% chance we might find it, if depending on the phenotype. But there is a 1% chance we will find a genetic reason for autism. If they are willing, we will ask for a whole exome sequencing of the index child. If it doesn't reveal anything, then the recurrence chance is 1.5%. and we cannot predict it beforehand. This is the counseling. If we find a genetic mistake that explains autism as its phenotypic manifestation, so that means a pathogenic, then we would test the parents and then we will go and test the fetus. So if you have a patient who has autism, before she is pregnant, you should send to us. Then only we have time. Not only autism, for every genetic suspected diseases.
Question for, can MTP be offered for hemoglobinopathies after 24 weeks?
After medical board discussion, I think.
Obviously after medical.
After medical board.
Thank you for a very nice pen. Okay, sir.
Sorry, I didn't explain why I said in our place it will end up in termination, because before I put a needle in a genetic condition, I will ask them, if it comes positive, will you do termination? This will be a very direct question. Most mothers will get a startle and then they'll settle down. Why? If you are going to do a termination, I will give you a genetic diagnosis prenatally, otherwise I don't want to disturb that fetus environment. So in that case, after the baby is diagnosed with a genetic condition, we won't be discussing about bone marrow transplantation. That discussion would have happened before. These are the treatment options. Do you want to test, find out, and terminate? Then I will test it for you. So that's the pre-testing counseling that will always happen.
So just one more minute I'll take, sir. So interestingly, we had a couple who had 2 previous children died because of glucose-galactose malabsorption, which is like a very rare thing to happen. And in the 3rd pregnancy, she said that if it's again affected, I would not continue. So we did it, the reports came out that the 3rd fetus is also affected with glucose-galactose malabsorption. And then she was lost to follow-up. She came to us finally at 32 weeks saying that I wish to continue the pregnancy. I've seen some mythological religious person in the family, and he has confirmed that the baby would be okay. And finally we delivered. The baby started again having diarrhea on the 2nd postnatal day. Then we arranged for glucose-galactose diet from Bangalore somewhere, and then finally the baby is doing so far okay. It's 1 month old, but that remains very important that you counsel them that if only we put in the needle if you are very sure that you discontinue the pregnancy. Otherwise, it's no point doing a prenatal diagnosis. Yeah, thank you.
Wow, very nice panel discussion, and thank you all the panelists and the moderator. And I will request all the chairpersons please come on the stage, and moderator too, for a group photograph of panel and for the felicitation. रुक जाइए, एक सेकेंड. Sharda Mishra ma'am, Chitra Jain ma'am, and Pradanya Harshay ma'am to please come and felicitate our chairpersons and panelists. Namita Tiwari ma'am, please. To felicitate our panelists and chairpersons. After this felicitation, we will have lunch. And Sharda Mishra ma'am to Ranu Jain, please. To Archana. Chitra Jain ma'am to Pooja Madhwani, please. Sulekha ma'am. Sangeeta ma'am, okay. Sangeeta ma'am to Anuj Jain sir, please. We are having a CME on LSCS, cesarean section. Dr. Parul Kotradwala sir is coming.
Interesting, a very important topic by our learned speaker, Dr. Shweta Bhandari. The topic says investing stillbirth, the current guidelines and practices. A very important topic for all the practitioner obstetricians. We welcome Dr. Shweta on the stage.
A very good afternoon, everybody. So we'd recently done this workshop on stillbirth, and sir wanted me to talk about it as to what we have, the new innovations or the new guidelines that have come up for investigating stillbirths. So we know that stillbirths, even in the entire world, there are about 2 million babies. The burden is quite high. For every year are born stillborn, and therefore it's not only for the mother, but it is for the entire family that it becomes a very tragic event. And henceforth the need that we evaluate stillbirth has come up so importantly, and it's the need of the hour. So why should we actually do an evaluation for stillbirth? Because ultimately we need to reduce the burden of preventable stillbirths. We should know how to prevent stillbirth, or maybe kind of understand the high-risk strata in whom we need to monitor more frequently and kind of identify those women or patients. Counseling parents regarding the risk of recurrence, because not all of these causes which are responsible for stillbirth would tend to recur in future pregnancies, but there are a certain lot which needs to be investigated and identified. And we have to kind of close the loop for the parents. We need to find out a cause. We need to tell them what is the probability it would happen again, what is the probability that, you would have a healthy baby in the future, and what are the guidance for interventions before and during pregnancy. If there's anything that we can do before itself to identify or test these mothers or the parents if needed. So who should ideally be involved in evaluation of stillbirth? So best is that we work as a team. So the obstetrician, the neonatologist, the geneticist, the perinatal pathologist is of utmost importance in giving us clues and insights as to what they have found out new. How many of us offer fetal autopsy or placental histopathology here? Yeah, okay, that's very nice. Yeah, okay. So we know that fetal death could occur because of many reasons. It could be just a placental dysfunction, it could be because of fetal anomalies, it could be just some cord accidents, maternal illness, maternal diseases, or maternal and fetal infections both. So the causes of stillbirth remain different for the different income countries. For the high income countries, as you can see, antepartum hemorrhage is quite a proportion here, congenital abnormalities are, whereas in the low and middle income countries, we are still dealing with a lot of infections for the mother or fetus, and even with hypoxic peripartum death that occurs in the low income, because obviously the population is so high and we have limited access to resources. So let's first understand the definition of stillbirth. A stillbirth is a newborn which is born after 28 weeks of pregnancy with no signs of life at birth, and or a birth weight of more than 1 kg. This is how the WHO defines it, but the RCOG or the UK guidance calls it a stillbirth even after 24 complete weeks of gestation. So a baby delivered with no signs of life, known to have died after 24 weeks, is what is the RCOG guidance. There are two types, the fresh stillbirth and the macerated stillbirth. So the fresh ones is anything that occurs within 12 hours of onset of labor, and obviously you don't see the full-blown maceration or skin changes or peeling that you obviously see in a macerated stillbirth. Now we need to identify women who have risk factors for stillbirth. So there are non-modifiable risk factors, which we can't do anything about them, or the modifiable ones. So the non-modifiable ones are nulliparity, extremes of age, advanced age or very young age, certain ethnicity groups like the black women and the Asian women, in which we also come up, a history of previous stillbirth, any adverse pregnancy outcomes like preterm birth, preeclampsia, all these diseases related to the placenta. So these are all our high-risk women. Multiple pregnancy we know has got a higher rate of stillbirth as compared to singleton pregnancies. Growth restriction, low educational attainment, they do not know about the fetal movement kick count, or the awareness is lacking. Maternal diseases like thyroid, thrombophilia, infections like malaria, COVID-19, cholestasis of pregnancy, which we all are very skeptical about monitoring them, when to deliver, when to time delivery. The autoimmune groups, SLE and renal diseases. The ones that are modifiable risk factors is pre-existing hypertension. You can always focus on strict control of hypertension, do a complete MDT team approach, involve the cardiologist, involve the dietitian, involve the perfect team to be involved. Obesity, overweight needs to be corrected before pregnancy. Smoking, that can be holding 10 cigarettes per day. Alcohol and drug abuse, going to sleep supine. We always have to tell our patients specifically after 28 weeks not to sleep supine. They should sleep on the sides. And living in areas of most deprivation. So assisted reproductive technologies have got, the ones who have conceived with ART have got a higher rate of stillbirth as compared to the singleton pregnancy. And also in this article, they focused on families who have repeated stillbirths. And they kind of identified certain gene clusters which tended to cause more of placental dysfunction. So gene variants which attributed to placental dysfunction, metabolic derangement, or certain genes which were crucial for in utero survival also were identified. And therefore they said that there can be a familial aggregation of stillbirth as well. So a family history of stillbirth also plays importance in identifying risk factors. Now the recurrence risk is mainly with certain causes. Abruption, we know there is a 9 to 15% risk of a repeat abruption which could result in a stillbirth. Vasa previa umbilical cord abnormalities tend to be non-recurrent. Turner syndrome is usually sporadic. Then trisomies, the full mutation, if they've had one child with a full mutation, full mutation trisomy like 21, 18 or 13, the risk is only 1 to 2%. Autosomal recessive disorders, we know there is a 25% chance of recurrence. And this lot, the placental disease lot, also has a higher risk of recurrence in future pregnancies also, which we always tell our patients all the time. The causes of stillbirth also tend to differ at gestational age in singleton pregnancy. So the placental disease lot, the preeclampsia, hypertension, abruption, they are more commonly seen in the stillbirths that occur in preterm fetuses. Whereas cord complications, infections are more commonly seen with term and post-term stillbirths. So we need to, that also tells us a kind of reason we should be thinking in directions of whether it's a preterm stillbirth or it's a term or post-term stillbirth. Now there are various classifications to stillbirth. The first one is the WHO ICD-PM classification. Then you have the RECODE and you have the Kodak classification. I would not go into a lot of details into this, but just touch upon what they basically kind of consist of. So the WHO ICD classification has classified it into antepartum death, intrapartum death, maternal causes, and neonatal death. And in those where they have given codes specific to that particular disease. The RECODE system basically came into play when they said that neonatal deaths differ from stillbirths and we need to have a separate classification for stillbirth as compared to the neonatal death. And it emphasizes on what went wrong but not why it went wrong. So there is a hierarchy here that they say. So starting from the fetus and then go outside. So fetus, cord, placenta, uterus, amniotic fluid, the mother, and then unclassified. So that's how the RECODE system works on classifying stillbirth. And then you assign that particular code on the stillbirth, that this is the reason why the stillbirth happened. And then they have different studies as to what is the recurrence risk. The third one is the Kodak classification, which is which basically is again according to the compartment of the cause. So it tells you the cause of death and associated conditions. So cause of death is called, AC is associated conditions that led to neonatal death or stillbirth. So again, same classification: fetal, placental, cord, maternal, intrapartum, infections, and unexplained. So these are just classifications. It's very theoretical. So now coming to the practical aspect of it. How should you actually do an evaluation? The first and foremost thing is that you take a detailed history of the mother as to is there anything relevant that could have led to it. Then comes the maternal examination, investigations, examination of baby, examination of placenta and cord, and then comes up the investigations. So what I'm going to discuss is the recent 2025 guidelines published by the Society of Maternal Fetal Medicine and their checklist that they have given for kind of working up a patient of stillbirth. So in clinical history, you have to take into consideration whether there was any environmental exposures, any medications which could have probably led to it, maternal infections, febrile illnesses, CMV, rubella, or sometimes any bacterial infections, malaria, which were preceding the event. Any history of trauma, we know trauma is a cause for abruption, then pre-existing medical history, a detailed family history that we saw that there could be certain aggregated genetic causes for stillbirth, cholestasis, and cholestasis has a very typical history of itching on palms and soles with a predilection for palms and soles, itching on the whole body, but it's mainly nocturnal on the palms and soles. That is what brings us to the diagnosis of cholestasis. Multiple pregnancy, the chorionicity, and detailed ultrasound findings. In cases of intrapartum stillbirth, we need to have a complete history of the labor. What was the gestational age, whether it was an induced or a spontaneous labor, what was the duration of labor, in how many hours, was it a prolonged labor, how many PV examinations were done, check the partogram, whether it was not a prolonged labor, monitoring of the mother, monitoring of the fetus, what was the mode of birth, duration of rupture of membranes, any malpresentations, what were the delivery details, color of the fluid, smell, baby weight, fresh, macerated. And all this is then incorporated into a relevant history form which we send to the perinatal pathologist, because then they're going to join the dots and then kind of make a conclusion that this was probably a reason which could have led to this. The second thing comes that we have to offer fetal autopsy. So all relevant information of antenatal intrapartum events has to go. You discuss the advantages that an autopsy provides in about 30% cases additional information to what you would have presumed to be, because it tells you about the depth analysis of the fetus. And in case many a times we come across couples because they've recently suffered a loss, they're not in a mental state to accept the fact that their baby would undergo another procedure. We can always offer them a limited autopsy or an MRI to kind of understand whether there was anything that they could have identified by non-invasive methods as well. So the components of fetal autopsy are external examination of the fetus, internal examination, examination of the placenta, microscopy, and radiological examination. So coming to placental histopathology and the evaluation of placenta in stillbirth, in which they said that this was actually a retrospective study in which they identified 1,000 women with stillbirth, and about 900 of them opted for a stillbirth evaluation, and a placental histopath was done, in which they identified about 30 to 40% cases to be of placental in origin. And abruption was a very common thing, with genital tract infection contributing to about 57% causes of stillbirth. And amongst placental lesion, maternal vascular malperfusion was a very important cause leading to stillbirth. And I'll come to details of ultrasound findings that can help us pick up these things maybe early and play a role in prevention. So what are the prerequisites for placental examination? Again, history I've emphasized many times. Transport of the sample, that the container size has to be adequate, the tissues have to be kept, and it has to be 10% neutral buffered formalin. The fixation is done by the pathologist. But before you put up the placenta or the fetus in formalin, it is important that you collect the sample for genetic analysis, because once the fetus or placenta is in formalin, the DNA gets denatured and we're not able to give you any results based on genetic analysis, which could also be contributory. So I'd like to thank Dr. Aditya Kulkarni, who contributed his slides. He's a perinatal pathologist in Hyderabad, and we often take advice from him. So these are some of his slides. Many of the slides related to histopathology belong to him. So this is the form that you actually have to fill up. He used to work in Apollo, so it's accredited to Apollo. And this is the container with formalin. You have to kind of completely submerge the tissue in the box, and then it is transported. The history is very relevant. You have to fill up all these history that you can see. The indication for examination, what is the history of the pregnancy, relevant history of prom, labor, maternal complication, and any medical history. So all this then goes. Then comes examination of the placenta, in which they do a gross and microscopic examination. On gross, they would do a compartment-wise study of the cord, the membranes, the placental disc, and all this is then evaluated to look for features of chorioamnionitis, any thrombus, any fetal malperfusion or maternal malperfusion, and all those things are studied on the placenta. Coming to autopsy, fetal autopsy, again the same thing, you have to fill up request forms. Consent is very important. You have to tell the parents that the baby will go a kind of a mini surgery is the term that I commonly use, because to tell them that it will be a post-mortem of the fetus is very unacceptable to many families. So in simplistic terms, we tell them that the baby will have to put a small incision on the baby's body. We are going to evaluate the internal organs. We might take out some tissue. If you want the fetus back after evaluation, we'll be happy to give it back to you after the examination is complete. And so it has to be a very cool and calm counseling and a long duration counseling for patients to be acceptable to undergoing a fetal autopsy.
Then again, sample transport and fixation. And we can do an autopsy anytime from 11 weeks of pregnancy until 7 days of neonatal life. So similar requisition forms, history forms, consent forms, everything is done. Again, it has to be saved in 10% formalin buffer, neutral formalin buffer, and this is how it is to be transported. The third component is the radiological examination of the fetus, and we call it a fetogram or an infantogram. It tells us about the fetal maturity, and it also helps us with diagnosis of various skeletal abnormalities and genetic condition that fetuses can manifest on the X-rays. For example, in this one, you can see this is a thanatophoric dysplasia. You have telephone handle long bones here. This is Fatco syndrome with an absent fibula and a bent tibia. And this is chondrodysplasia punctata, in which you can see stippling of the epiphysis here. So a fetogram also helps in many ways. Many a times patients are very reluctant, we don't want to undergo anything. So at least you have the placenta, placental histopath can always be sent. X-ray doesn't cost us much, we can always take an X-ray and pictures of the baby. So even if we have limited information, sometimes the geneticist or the perinatal pathologist can provide us very important clues to kind of clinch onto the diagnosis or possible diagnosis which could have led to stillbirth. So that's about fetogram. Then you do an external examination of the baby. You would examine the baby from head to toe, facial features, the trunks and the limbs, examination of the perineum, the anus, the spine, and any additional features that you could probably see in the baby. So this you can see is a Potter's sequence because of silver oligo, syndactyly here noted in the fetus. This one was arthrogryposis. You can see this pterygium or folds on the neck, so it could be a multiple pterygium syndrome, occipital meningocele, polydactyly. So all this comes in a part of external examination of the fetus. And then is the internal examination that we were discussing, that you give this inverted Y-shaped incision on the chest and the abdomen of the baby, and then you follow a system-wise approach, which the pathology people do and then evaluate. Then they make slides from the various viscera to understand whether there was an infection or any errors of metabolism that could possibly be linked. The third part is that you offer a genetic assessment, and I've not heard of offering amniocentesis prior to delivery, because I think in our setup we always do it post-delivery, sampling of the placenta or the cord or the fetal tissue. But this was there in these guidelines, and they said that if you have not performed an amnio, then you can send a portion of placenta or cord. Maybe it's because in the amniotic fluid you're more likely to get a good yield of the DNA, and if you had to run a karyotype on as a test, because you get more viable DNA, whereas in the dead tissue the reporting is not enough when you have non-viable tissue. And then genetic assessment, it could be a karyotype, microarray, or whole exome sequencing, or gene-specific test if you suspect any long QT syndrome. If there was a heart block or something, then you could probably think of those things as well. Then parental consent for all cytogenetic specimens has to be taken. What are the samples that you could probably retain is amniotic fluid obtained by amniocentesis, a block of the placenta taken from below the cord insertion, cord segment, or internal fetal tissue specimens such as the cartilage from the costochondral junction or the patella, or even muscle biopsy is something that we send off. Once you have the consent for fetal autopsy, then it is sent, the fetal autopsy and placental tissue is then sent for examination. So the first thing is you obtain the sample for genetic analysis, then you put the fetus and placenta in formalin and send it for evaluation. If the consent is not given, then you can do external evaluation, X-ray, ultrasound, MR, whatever is possible in the minimal invasive way to kind of gain information. So apart from all this assessment, in case we can offer testing for feto-maternal hemorrhage using the KB test, you should offer APLA screen to all women who have undergone, who have had a stillbirth, and even screen for syphilis. If the clinical history is suggestive, then you do an infection screen also. So you screen for the mother's blood for CMV, toxo, COVID, HSV, assessment of diabetes with HbA1c and urine toxicology screen, bile acids in case of suspected cholestasis, anti-Rho, anti-La antibodies, and sequencing for long QT syndrome or channelopathies if suspected. If fetal and maternal infections are suspected, then this is the RCOG list of the infections which are known to cause stillbirth. It could be transplacental or it could be ascending infections. So transplacental we know are many of the viruses which are known to cause it: syphilis, listeria, malaria. And ascending infection is more of by the bacterial group, the E. coli, Klebsiella, group B streptococcus, and ureaplasma, mycoplasma are also known to cause it. If the clinical history is suggestive that the mother had fever, she had any flu-like symptoms, the liquor was purulent or foul-smelling, in those cultures, you would send these tests also for the mother. Cultures, midstream urine, vaginal and cervical swabs. This is the bacteriology workup. And in case you suspect viral infection, then you do the viral screen, syphilis, and screen for tropical infections also. Coming to the fetal workup for infection, so you can either take fetal blood or fetal swabs. The fetal swabs are mainly the oropharyngeal swabs that you have to take for workup for fetal infection in suspected infection as a cause for stillbirth. So let's come to a case. So this was a 31-year-old primigravida. She was low risk on combined FTS. The moms were 1.47 for beta HCG, Pape was 0.36. She was intermediate risk for trisomy 21 on combined FTS. She underwent a NIPT, the NIPT was okay. And then she came to us at 21 weeks for suspected early onset FGR. And it's not a very great clip, but just to show the placenta. It's a small video if you again want to see it. So we can see the fetus, we see the placenta as a large, thickened placenta. And on measuring, the thickness was about 6.9 centimeters. And this was the biometry, and we can see all the growth centiles were falling way below the 5th centile. The amniotic fluid volume was normal, and the placenta was in a normal location. There was an associated single umbilical artery. The uterines were bad. It was above the 95th centile for gestational age. And finally, this patient was counseled to have an amniocentesis to rule out all possibilities that we do for an early onset FGR. She had a spontaneous fetal demise at 26 weeks, and she delivered without any maternal complications. Again, the workup for any stillbirth in our unit is placental histopath, fetal autopsy, infantogram, maternal torch, genetic workup, thrombophilia workup, HbA1c if suspected, bile acids if suspected, and that is what we do. So she had a normal CMA on the POC sample, so genetically it was all okay. The fetal autopsy was fine. The infantogram was not suggestive of any skeletal dysplasia. But the placental histopath here helped us pick up the clue. So it was a massive subchorionic thrombohematoma, which we saw as the large enlarged placenta, and there was a single umbilical artery as well. And when we studied this massive subchorionic thrombohematoma, it's called a bruise mole. It's a very rare entity in which there is extensive deposition. And it's been linked to poor pregnancy outcomes and placental insufficiency as happened in this pregnancy. It's known to be associated with maternal heart disease. However, it was not the case in our patient. The ultrasound findings are suggestive of thick placentas, hematomas, and irregular cystic areas. So can we actually do something to identify these high-risk placentas when we see them antenatally or anticipate maybe stillbirth? So one of our faculties was Dr. Edgar Hernandez from the University of Texas, and he showed us this beautiful diagram of hematomas related to their location, and I thought of sharing it with all of you. So when you see this is the umbilical cord, the location of the hematoma tells us or helps us classify whether it's subamniotic here just below the amniotic membrane. It's a subchorionic. This is a retroplacental behind the placenta. These are intervillous thrombus. Again, a rounded intraplacental hematoma. This is the massive thrombohematoma that we just saw on the ultrasound image. It is a full thickness placenta involved with the hematoma. And then these are marginal hematomas. So if we do a good scan and we look at the placentas more carefully in our high-risk lot, maybe some of them we could identify. It's not a recommended way of kind of screen for stillbirth or anticipate stillbirth, but I thought because it was something new that we learned, so I thought of sharing with everybody here. And in this article by Dr. Edgar, he suggested that these are the conditions we could probably screen for which could lead to stillbirth. So one is vasa previa, and we'll come to each condition. And how do we differentiate between all these conditions, the placental lakes, infarcts, thrombohematomas, and maternal pelvic floor infarction. So this is how a placental lake would look. It's an irregular hypoechoic area. You would see flow within the hypoechoic space, and usually it's the spiral artery pouring into these. And placental lakes are usually benign, and you would see flow around them and also into these spaces. But lakes more than 5 centimeters have been weakly associated with fetal growth restriction. So that's how a lake looks like on placenta. Coming to vasa previa, we know that it's an important cause of fetal exsanguination when the patient is in labor, or if you do an ARM and you see that there's a gush of blood and there's a deceleration happening or something, you should suspect a previa. And you should always screen when you are doing a transvaginal scan, look for any vessels across the internal os traversing here, and then you can suspect vasa previa or diagnose vasa previa, and they are to be delivered electively by C-section somewhere between 32 to 34 weeks. Then coming to infarction and infarction hematomas, this is how infarction looks like. So, but unlike lakes, there is no flow inside these hypoechoic spaces, and they have this hyperechogenic rim around them. So that's how you differentiate a lake from a hematoma. And this is a infarction hematoma, a hematoma happening within an infarcted placenta, and this is usually associated with poor perinatal outcomes. So if you see an infarction hematoma, you should be very suspicious that this could be something we are dangerously looking at. And then coming to maternal floor infarction, which we report as massive perivillous fibrin deposition in many of the ultrasound reports. And this is usually an enlarged thick placenta, multiple tiny areas that you see inside them with minimal blood flow surrounding them, and it's an enlarged placenta. So they also have a very poor associated perinatal outcome. Apart from this, many a times we see requisitions coming for diagnosing placental abruption, but ultrasound as such has a very low sensitivity for picking up placental abruption, but if suspected, it has a very high positive predictive value. So acute and recent hemorrhages usually appear hyperechoic, and old hematomas then start appearing hypoechoic, and the Doppler would not show any blood flow movement inside the abruption areas. Then we can also look at the coiling index. So the coiling index is nothing but the number of coils of the umbilical cord per 1 centimeters. So the normal range should be 0.2 plus minus 1. So if it is less than 0.1, we'd say it's undercoiled. If it's more than 0.3, we say it's a hypercoiled umbilical cord. And they have also been associated with SGA or FGR or hypoxia as well. So that could be the ultrasound features that we might start looking for in our high-risk group sometimes, or we look at the placenta, because many times we just keep the probe on the placenta, check the location, and that's it, the grade of placenta. But we have to look inside the placenta to identify these hematomas and thrombosis. The FOXY recommended checklist for stillbirth workup is all these tests that we are, I believe, commonly aware of. The maternal test for the hemogram, the renal and liver profile, TFT, bile acids, HbA1c, group and antibody screen, coagulation disorders, and APLA. For the fetus, again, external examination, clinical photographs, full partial autopsy, postmortem, and placenta for histopath and CMA. So that's what we just learned across all the slides. And when you have this patient with stillbirth, so if you have no clinical clues, ideally you should do a full workup, genetic testing, APLA workup, feto-maternal hemorrhage screen, and other testing as indicated based on the history of the patient. If you have a FGR or hypertensive disorder, then also you have to offer genetic, APLA, feto-maternal hemorrhage. Suspected anomaly, so you would do genetic testing. Intrapartum stillbirth, APLA, feto-maternal hemorrhage. And preterm labor, choreo, prom, and all these scenarios also based on your clinical judgment, but in all of them they finally suggested that fetal autopsy and histopathology in all patients of stillbirth has to be suggested. So once a patient has had a stillbirth, there's a checklist that they have given for subsequent pregnancy management, in which pre-pregnancy, if the patient comes to you, so try and figure out the medical history and all the evaluation which was done in the previous pregnancy. Determine the recurrence risk, what was the cause, whether it was an abruption or whether it was preeclampsia or anything, smoking cessation, weight loss, the things that we generally do in our routine clinical practice, screen for diabetes, genetic counseling if there was a condition identified, and APLA. In first trimester, a dating ultrasound is very important so that you know you're not going to change dates and miss out on identifying growth-restricted babies. First trimester screening involving the HCG, PAPE, and support and reassurance. Again, second trimester, fetal sonographic anatomic survey, genetic screening if it has not been performed earlier, and in the third trimester, growth surveillance from 28 weeks and as indicated based on further assessment. Delivery is usually planned at 39 weeks or based on any other complications or clinical assessment. If you feel it should be between 37 to 39, or if the patient is very anxious, then based on particular scenarios, it can be accustomed. And the Stillbirth Society of India has then published this Safe Baby Bundle, which is the SBSI Safe Baby Bundle, and they kind of focus on regular health checkups for the pregnant women, diet, monitor weight, monitor the baby's movement, quit smoking or tobacco, sleep on your sides, and institutional delivery. Don'ts, they have published as avoid self-medication, avoid contact with sick persons to avoid acquiring any infections, and smoking or alcohol avoidance. Sleeping position in pregnancy to be educated to all patients that sleep on your back. After 28 weeks on your pregnancy increases the risk of stillbirth. So what is suggested is that you sleep on either side. And that is how you should always be very aware of the movements of your baby. Not all babies move alike. You have to know the pattern your baby moves. Any change in perception of movements you should be reporting to your physician is what they've suggested, and general advice, and just be more tender, supportive, and careful for them in all future endeavors. And I'd like to thank Dr. Aditya for his contribution to this presentation. And he's basically based in Hyderabad. He's a perinatal pathologist with various publications, and he's been doing this work for the last 5 to 10 years in the field. And thank you very much for your patient hearing on this elaborate topic.
Thank you, Dr. Shweta. It was an excellent talk. And stillbirth, having a stillbirth is a nightmare for not only the family, the obstetrician, and there's so much of crowd and all this medico-legal complications. I think we have to recommend fetal autopsy.
Yes.
In our setup, we usually advise and we take a written consent if they are not willing to do it.
Yeah, that's the best we can do.
Yeah. And the follow-up chart was very good.
Yeah, okay, thank you, ma'am.
Can you give the slide later on?
Yes, ma'am, I'll share it on the group so you can all have it.
Okay, thank you so much.
Thank you.
And when to refer? By our Dr. Krishnan, who's been here since morning. He's going to give more information about it. Thank you.
For putting up. How many of you are interested in mythology? Very good. So I've come to the heartland of mythology. See the 4 figures there. There's Ashtavakra, who's a sage, cripple. There's Hanuman, godly or God. There is Prahlad, attains salvation, short but attains salvation. And then there is Abhimanyu, a hero forever. What is the common line? Say that, madam. Confidence. Preterm. Something you should connect to the topic also. Correct. So, excellent. So, they all had a fetal intervention. Okay? Ashtavakra was cursed. Hanuman was given the blessing. Prahlad was given the tutoring for devotion. And Abhimanyu was given the pathway to enter the Vyuga. So that's what happens when you do fetal therapy also. You should be ready for complications, short but good life, long life, and we may not know. What we will do is we will take you through scenarios of fetal therapy, and then we will understand when to refer or call for fetal therapy. So we'll start with the placenta because Shweta madam just now finished with placenta. There's one cause in the placenta that may require a fetal therapy, and this is that. There is a tumor in the placenta. So this lady was 29-year-old, third gravida, first one full-term cesarean section, second one spontaneous miscarriage, and the third one was referred because the obstetrician saw that there was polyhydramnios, and she also picked up that something wrong in the placenta. So it's good all of us see the placenta, very important. So she called and I said, yes, this case you send now only. This is something we have to do because I understood what she is talking is a chorioangioma. Chorioangioma, very common. If you send all your placentas to the histopathologist, pathologist, you will see 1 out of 100 or 1 out of 50 chorioangioma will be reported. But when it crosses 5 centimeter, then it is called a giant chorioangioma, and the giant chorioangioma is a problem for the baby because it will act as a burden, hemodynamic burden for that small fetus's heart, and quickly, slowly but surely, that heart will go in for high output cardiac failure. And we will know that there is high output cardiac failure when you find poly, cardiomegaly, tricuspid regurgitation, and distension of the umbilical portal vein system. Sometimes, instead of being a shunt causing a high output failure, it can sequestrate all the RBCs. Then the baby will manifest as high MCA PSV, causing a anemia-like situation. In any such cases, that is the time that we should intervene. So if you have a good sonologist, you monitor for this. Otherwise, the moment you see a chorioangioma which is 5 centimeter or more, that's the time to refer. So what do we do when we see a giant chorioangioma that is imminent on harming the baby? We have to devascularize it. All the problem is because of the feeder artery. So we have to devascularize it. We can, it's like our, let's say a gynae surgery. You want to obliterate a vessel, so you can apply various methods and coagulate that vessel. So you can do it from outside. You can go with a fetoscopy. You can go with a needle, give laser. You can do a radio frequency ablation. So these are energy-based vaso-obliteration. But what we can do even better is we have ultrasound. We can go inside the feeder artery and then occlude it by giving a coagulum or a gel, tissue glue. Right. So this is the scenario, that's the giant chorioangioma. The only important thing is you should go into the feeder artery. So if you have that much confidence and accuracy with your ultrasound, take a 22G needle, the needle that you use for amniocentesis, go into the feeder artery. You can see that we have injected the tissue glue. The moment it is injected, the moment it comes in contact with the blood, it becomes a coagulum and it blocks off the feeder artery. You can see that avascular necrosis has happened, it has become black, and then the fetus will recover. So if, depending on when you intervened, it would take about 1 week, 2 weeks, or about 3 weeks to recover, but the baby is in the best NICU, which is the mother's womb, so it is always recover, and then you can manage the pregnancy like any other obstetrics with regards to delivery. Okay, let's go to monochorionic pregnancy, which is a slight touch on monoamniotic also. What is your greatest fear about monoamniotic pregnancy? Cord entanglement, yes. Monoamniotic pregnancies will have cord entanglement present in dash number of cases. What is the proportion? Who said cord entanglement? You should follow up. 50%, 70%, 90%, 100%. 100%. 100% of monochorionic pregnancies, monoamniotic, will have cord entanglement, but the fetuses don't die. Why? Because God has given the Wharton's jelly. But the problem comes when one of them die or we do a cord occlusion procedure. When we cut off one baby, then Wharton's jelly will dry up and it will become like a nylon string that will strangulate the other baby. Right. So when do you go and do a cord occlusion in a monochorionic pregnancy? When one baby is going to die on its own, let's say severely malformed or severely small, selective fetal growth restriction. If one baby dies, then through the connections in the placenta, the alive baby will push its blood through the connection into the dying twin. So this baby, which is the dying twin, will receive all the exsanguination from the normal twin. The normal twin will experience profound hypotension and will suffer either death or severe cerebral damage. So if you find in a monochorionic pregnancy that one baby is problematic, is going to die, then you have to disconnect the circulatory connection. Typically we do by disconnecting the umbilical cord. So we can do that disconnection by interstitial laser, radio frequency or microwave. So all are energy. It's like your monopolar cautery or bipolar cautery. That's all, same. We do an energy and coagulate the cord. But when it is a monoamniotic, you can't use any of the first three shown here. You have to go for bipolar cord coagulation. So this is small fetuses. This is monochorionic diamniotic. I am putting a needle inside. Through that needle, I send a laser wire and then I coagulate the umbilical cord within the baby's tummy. So you can see the coagulation happening here. So this cord occlusion in a dying twin situation in a monoamniotic will only mitigate the risk of co-twin exsanguination. The cord entanglement risk always remains, and it's actually higher when you have done a selective fetal reduction. So in order to mitigate that risk, in order to prevent death from that, you need to do a further procedure that's called cord transection. So if you want to do a cord transection, firstly your method of cord occlusion should be a bipolar cord occlusion. So here you can see, instead of needle, I have put a bipolar clamp into the amniotic cavity. The dying twin's cord is caught and then ablated. We do it 3 or 4 places so that we know it's completely occluded. Then we have to put a fetoscopy inside and then see, this is the cord occluded area. So all those constrictions are the coagulated area. Once that is done, then you put the fetoscopy, do a laser fiber, and the laser fiber will now fire the laser, go and use that to transect it. So cut it off from the demised twin. So we have already done the selective fetal reduction, now cut off. Now the freely hanging umbilical cord, this will not act as a strangulation on the other twin's cord. This will be freely hanging, it doesn't happen. So the other fetus will be floating away freely. Alright, now let's go to a very special situation. So the patient is a 26-year-old, 6 years married, no child at home, 1 ectopic. So primarily she is nulliparous. She comes, once again, it's the same obstetrician. So she said, my sonologist has picked up a goiter in the fetus. Do you want to have a look? So it's like Jabalpur and 100 kilometers, no? So like that we have one referral pattern. So I said, yeah, 29, you are telling infertility, let me have a look. Fetal goiter, very unlikely with what you told, but let me have a look. So she came, this is the tumor. It's a fleshy tumor of the neck, solid tissue, and a little bit of specks of calcification. That means this is a giant cervical teratoma. Now, once you see a giant cervical teratoma in the fetus, the first thing that we should think is what is happening to the trachea. So, what we have shown is fluid inside the trachea, red, blue. So, that means it's going up and down during fetal movements. So, the airway is patent. But we know this teratoma is going to grow, and there are going to be three major issues. Antepartum, because the trachea and the esophagus is going to get occluded, it's going to have progressive polyhydramnios and at some point PPROM. Because it's a big tumor in the front of the neck, it's going to be an extended head, and that's not going to have any mechanism of vaginal birth. So you need to go with a C-section. But these are manageable. What is difficult to manage would be after birth, the neonatologist will have about 4 minutes to find the distorted airway because it will be obstructed, and therefore the poly. You have to find and intubate within 4 minutes, otherwise the baby's brain is fried. So that is the more concerning and less under control. So we counsel that. Long ago when I was faculty in JIPMER, we did our first exit for such a scenario. But exit means ex utero, intrapartum therapy will require that the mother is put under very deep general anesthesia. You want the uterus to be extremely relaxed and placenta not to separate. It's the exact opposite of what we want in a section. We want a section, uterus to contract, we deliver the baby, immediately placenta should come out. In exit, it's the exact opposite. Therefore, there is a risk for the mother of hemodynamic instability due to the anesthesia. There is going to be PPH from atony, also PPH from the cut edge, because you will be intubating the baby on a cut uterus. So with these things, we should balance the procedure related risk or the alternate procedure. So when there is a large neck mass in a fetus, anticipate airway obstruction. If there is polyhydramnios, definitely there will be airway obstruction. So what we did is a minimally invasive procedure. We want to secure the airway. Why deliver the fetus half, put the mother at risk? We know from fetoscopy experience, we can intubate the fetus inside only. So here, anesthesia is given just like your cesarean anesthesia. Do a phalangeal incision. Go to the laparotomy part, you finish, but don't do the hysterotomy part. Anesthesia is the same, just we have not started any oxytocin like in a C-section. Now once you have reached the uterus surface, under ultrasound guidance, so I take the fetoscope, then connect it to a camera, then thread the fetoscope with a ET tube. So now the fetoscope is loaded with the ET tube, and then I enter the amniotic cavity. Once inside the amniotic cavity, you can see that's the baby's mouth. Go from the angle of the mouth, enter the mouth. You will see the tongue on one side, palate on the other side, and keep tracking along the palate. So it's a very small camera, so you will see only that much. Once you have gone to the epiglottis, that means you have come to the right place. So epiglottis is what you have to find. Because of the tumor, there will be distortion, so you need to go search and find out. So then what I did, I know after the epiglottis, left is esophagus, right is trachea. So we want to go into the trachea, find the vocal cord. You can see already that the vocal cord is constricted and narrow. You go past the vocal cord, the upper trachea is fully occluded. So first thing about, this is called feti. First thing about in utero intubation is, we can justify whether we have to intubate or not. If this trachea is not obstructed, at this point we can come out, don't do anything. Postnatally the neonatologist will manage, baby will breathe without assistance. But now there is an obstruction, so you go past the obstruction, put some, flush some saline, and then it will dilate, then go past, and then reach the carina. Once you see the carina, then that's your landmark. You have already loaded the ET tube, push it inside. That's all. Push it inside, remove the fetoscope. Now, you have not opened the uterus was quiet, under anesthesia, you have intubated the fetus. Now you can proceed with your caesarean delivery. So, usual section is done. You can see the liquor flowing out, plenty of liquor, and then deliver. But the baby has the tube inside. the airway. So it's a ETT, in situ delivery. So the obstetrics part was handled by the professor there. We delivered it in a medical college. So that's the ET tube, immediately secured and handed over to the neonatologist. And this baby had a very large tumor. It was weighing 250 grams, and the whole baby was 2750 only. So immediately it became a 2.5 baby. On day 2, excision was done. Luckily, no cancerous elements, and the baby did well. 1 year birthday I attended. So the difference is, exit causes a lot of trouble for the mother, and you can omit all of those trouble, do a diagnostic laryngoscopy, decide if airway needs to be secured, and then come out. If needs to be secured, you can put a ET tube and come out. It's just a minimally invasive intubation. Now let's go to when we have a problem with the placenta. So morning I had told how to monitor monochorionic. While you are monitoring monochorionic twins every 2 weeks, if you meet oligo and poly, that's a bad situation. Many times you will meet oligo normal or normal poly. Those are okay situations. But if there is a combination of oligo and poly, it is TTTS. Now in TTTS, it goes in stages. Sometimes it can jump stages also. But whenever there is profound poly, or if bladder discordance have started appearing, or there is a Doppler discordance, then we have to intervene. So the moment you see CTTS is the best time to refer. Don't wait for stage 2, thinking that only in stage 2 we will intervene. Mostly we will intervene in stage 2, but the best time is to refer immediately when you see, because it can skip stages. So how do we do it? The TTTS, although it's like a minimally invasive, put a scope and all, is still done under local anesthesia in a OT setup. So that's me giving a local using a long needle. So we infiltrate up to the myometrium and come out, and then we enter the polyhydramniotic sac. We don't enter the donor sac. The poly sac you have to enter, and we enter it by, it's like putting your second port in a laparoscopy, already well distended. So here, instead of putting a direct, we put a needle, guide wire, over that we put the secondary port. All right, once we go inside, then once we get the access, we put the fetoscope, and then under continuous monitoring, this is my second consultant, Dr. Ponmari, doing it. So we go inside and we check from any of the landmarks that we get. This is the recipient's umbilical cord getting inserted on the placenta. So you start from any landmark, then you trace all the vessels that connect the recipient and the donor. Only those vessels that you see are making an abnormal anastomosis. They have to make an abnormal anastomosis, only that you take. The remaining normal vessels, you leave it back to the fetuses. So in this way, you create a functionally dichorionic pregnancy. Once all the anastomosis have been lasered, the procedure is complete, the excess liquor is removed, and then you come out. It's a major invasive surgery, and therefore it's not without risks. We counsel the mother regarding all these risks: intraoperative, recurrence, then leaking risk, and maternal risks are very, very rare. Now, let's go to the common procedure, that is anemia. So we can transfuse blood. The most common indication in my practice is still RH, even though it's actually less than in the northern parts of India. So this is a fifth gravida. First received anti-D, but miscarriage, she didn't receive anti-D. The third was an IUD. It was reported as IUD. Most probably it must be a hydrops related IUD. Fourth one was terminated because it was hydrops. This will never end. In RS disease, it will only keep getting worsened. So you must treat and save the baby that you identify in the first go. Today, the diagnosis of anemia does not require an amniocentesis. There is no Lilly's chart, just MCA PSV. And as I told in the morning, if the peak systolic velocity is twice the gestational age, that's time to transfuse. And the principle of transfusion is simple. Unlike the neonatologist, we don't do an exchange. We just pour a very concentrated liquid into a very diluted fetal-maternal blood and it equilibrates. Now, when do we transfuse? If the MCA PSV is, so this is how you should refer. If you can keep monitoring or you can ask them to monitor, the fetal medicine people. When it reaches 1.5 mom, or if it reaches 1.3 with other B mode signs, the gray mode signs are there, or if there is frank hydrops. In all these cases, we transfuse. So this slide I showed in the morning, I prefer the umbilical portal junction. So this is the junction. The reason is it's quite safe. There is no artery by the side. Anywhere else the umbilical vein will have an artery by the side. And here, even if you go to the side, if it extravasates, it will be within the baby's peritoneal cavity and there is no much exsanguination risk. This also we discussed in the morning after transfusion, how to manage. I should say that one of the most rewarding therapy in fetal medicine is transfusion in RH disease. You will get the baby always. So don't ever give up on an RH. We have saved with hemoglobin 1, hemoglobin not detected, all those things we have saved. So never give up on a RH disease. Let's go to the next one. What is the diagnosis? Huge pleural effusion. You can see that the ipsilateral lung is totally collapsed, contralateral lung is compressed, mediastinum shifted to the opposite side. This is called tension hydrothorax. When this situation happens, more likely you have to do a therapy. But when you see that, the treatment for fetal therapy you have to refer when you see a tension hydrothorax, all right. If you see reaccumulation after the first step, whatever is the tension hydrothorax, the first step is a diagnostic tap. 1 in 6 fetuses would resolve with a diagnostic tap. So first thing is do a diagnostic tap. Also ensure that the genetics are okay. If there is hydrops or incipient hydrops, then also you should refer for a shunt. So how do we do the shunt? We carry it's a double pigtail catheter that is loaded inside a large needle, not like the fetoscope threaded outside. This is loaded inside. So we go enter with that needle. The trick is to put the shunt on the subscapular region. So you need to position the baby if required, make it come to the correct position, find the scapula, so it will take some time, and then enter sharply into the fluid region. So here you can see I have positioned the baby nicely, and then I am going to look for the scapula. That's the scapula. So once I look at the scapula, I go below the scapula, and then I enter it with a sharp entry. Yeah. Once we have entered, then you can deploy the first coil inside. You can see that the first coil is coming inside. Then the second coil. Once you deploy the first coil inside, the second coil is deployed outside. That's the second coil. So that will be outside. You just pull it and push it out. It's like your copper T insertion only. So you withdraw, it will open, keep withdrawing, it will open again. So now we have the catheter nicely positioned across the chest wall. So it should be subscapular for it, otherwise the next day itself the baby will grope around and pull it out and show you. So it should be subscapular. Even with subscapular positioning, there is a 20% chance that the baby will still pull it out or it can migrate. That's the baby there. So the success jumps from 50% survival to 90% if you do a shunt. Okay, so these were all direct therapies. Now what about indirect therapies? Let's see this situation. Second opinion at around 29-30 weeks referred for tachycardia. So you see that is the umbilical heart rate. So you measure the umbilical heart rate, it's going. So we will also get tachycardia, isn't it? For 232 beats per minute. At this stage, we won't know how long this baby is going to wait. But the moment you see umbilical artery tachycardia, you must go to the fetal atria and ask what is happening there. This is the atrial rate and it's 462, twice, maybe more. That means it's a special situation called atrial flutter. Atrial flutter at this incessant, we have seen, means within a week it's going to go into high drops and we may not be able to get the baby properly. So in fetal tachyarrhythmia, there is a risk of going into high drops if it persists. That is your threshold. If you see tachyarrhythmia, you should immediately refer. What is the therapy? The therapy is usually indirect, not direct. We admit the mother under an adult cardiologist, then we give the medicine for the fetus. But to get the therapeutic dose in the fetus, we will be giving supratherapeutic dose in the mother. So the mother has to be carefully monitored because she should not end up with antiarrhythmic toxicity. When there is a high drops, when she takes orally, it may not pass through the hydropic placenta. So in those cases, we can give a direct intragluteal injection to the fetus. So after starting sotalol in this case, within a week, atrial rate, ventricular rate, everything came under control. We continued her. At 37 weeks, she was delivered by repeat LSCS. Baby was vigorous and fortunately, the baby did not require any treatment postnatally. That's the story in many of the arrhythmias. And even if they require a treatment postnatally, it can be medically managed and the prognosis is good. Let's see the last one. Lungs, from the heart lungs. This is third gravida, previous intrapartum demise. So, a very sad story. But now in this pregnancy, at Target, again, it's a different 100-kilometer town. They said it's high drops now, you can't save the baby, but maybe you go there and come. So they came here, we also saw the high drops and we were like, oh no, what is happening? But the moment you move the probe to the chest, you can see the reason for the high drops. It's a thick, fleshy, solid tumor of the lung that's causing a massive space-occupying effect. So this is a solid or microcystic CPAM, and this is the reason for the high drops. It's good news. In solid CPAMs, if the size of the CPAM is 1.5 times more than the size of the head. So CPAM volume you calculate, HC they would have given, divide, if it's more than 1.5 times, then that's the time for you to refer for therapy. So because 1.5 more than 1.5 times, there is a risk of high drops. If it's already in high drops, then also therapy is required. And the therapy is the same as our antenatal corticosteroid. Same. It's to do with the lung, same. You give this therapy in one dose, 70% of fetuses will start resolving their high drops. If it doesn't help, in 2 weeks' time you can give one more. There is a 80% success rate. 8 out of 10 fetuses, even in high drops, will come back. So in this case, they received 2 times, and with every visit, we could see the normal lung expanding and the tumorous component shrinking. So ultimately, at 39 weeks, they delivered a nice female baby, and the baby did not require any treatment after birth, because that's the story of CPAM. It will always keep tending to regress only. Transplacental therapy, all of us know that what we give for antenatal for prematurity, steroid, that's the first and most experienced transplacental therapy. And then the cerebral palsy, MaxSelf, what we are giving now. So we saw tachyarrhythmia, we can also give for thyroid, congenital adrenal hyperplasia, and RH disease also. Fetal therapy is not without complications, so you must know that. So when you are only pushed to the wall, without your treatment, the baby will suffer hugely or will die. Only then we give fetal therapy. Maternal complications are very, very rare in today's practice because we have very good ultrasound machines, so we go carefully. Obstetric complications like preterm birth and PPROM, very low risk when you do procedures using the needle, including that shunt. But for all fetoscopic procedure, it's about 20%. Perinatal, that fetal demise, that depends upon for what reason you are doing. What is the disease for which you are doing the fetal therapy? So that will determine the perinatal death rate. So I conclude here, This is a gist of the current fetal therapy that is available, which have the potential to convert a bleak prognosis without therapy, such as TTTS, tension hydrothorax, complicated monochorionic, chorioangioma, or fetal anemia. No therapy, the outcome is bleak, but with therapy in the right hands at the correct moment, the prognosis becomes north of 90%. Thank you very much.
Hello, Dr. Krishnan, I must confess, it sounded like fairy tale and fantasies to me. You're doing excellent work, and it was a beautiful presentation, so we'll know what to do next time, just in case if we think of hydrops. Just one question, just in case if you see, if there's a twin pregnancy, 19-20 weeks, and if you see one fetal demise, so can you do cord occlusion and continue with the second pregnancy? Because I just recently, 2 days back, I had the patient, it was very precious, but her coagulation profile was changing. The FDP was constantly rising, doubling each day. So I took a decision of terminating the pregnancy, although they were asking me if there is any other way. I didn't.
Only in monochorionic pregnancies. So in the first trimester, you say dichorionic, monochorionic, that we should decide. If it's dichorionic, and one baby is not growing, AEDF, we do a counseling where we will tell explicitly, this baby is going to die. Even if it dies, the other baby will not have any direct impact. You will also not have any direct impact, just follow.
But then this was a diamniotic, dichorionic pregnancy, but then why were the FDPs rising?
Correct. So the recommendation is, don't do maternal surveillance. It does not have any implication in the management. That FDP will settle down. We don't recommend doing any maternal thing. Consumption coagulopathy risk is negligible or zero. Don't do it.
I think it is a very great his lecture also, because of paucity of time and because of their train. I thank the Devashish to agree that he will have his speech after this quiz session. So because Avantika has to go and their train is, I think, 4:30. So with them, I think students are also there no, with you. So I request, Komal, please go ahead.
So we are forward, and I will request Dr. Nidhi Jain, Dr. Rajya Siddiqui ma'am, and Dr. Disha Paryani to please come forward to felicitate our chairpersons for this session.
Please stay with us. We have a very attractive bumper prize. And you must have seen the rules of that. Whosoever is here in the room and whosoever deposited their tickets in the bottle, I request them to stay here, and after that Devashi's talk, we will have that bumper prize.
And out of the 9 teams that have participated, we have done a screening round and selected 4 teams. So I'll be calling out their names, and this is not on the order of how much whosoever scored. It's just a random list. So don't feel bad that whether we were first or fourth. So this is just a random order. So team A, Dr. Sushmita and Dr. Ankita from AIIMS Bhopal. I think we should encourage them. They've already participated in the screening test and won these 4 teams. Team B, Dr. Seema and Dr. Pratibha from Sagar Medical College. Dr. Seema, Dr. Pratibha. Team C, Dr. Vidhi and Dr. Rishu from Jabalpur Medical College. Team D, Dr. Shruti and Dr. Ranjana from Jabalpur Medical College. Questions, and you will have 2 minutes time. You have to answer as many questions as you can, and you will be marked according to it. Okay, we have written 30 seconds per question, but we'll give you 2 minutes in total. It's a one-line answer, there'll be no options. There will be no passing, plus 10 for one correct answer, and plus 5 if a part of the answer is correct. Okay, there is no negative marking, so try to attempt as many questions as you can. Okay, so we'll start with team A. Strawberry shaped skull is seen in which syndrome?
Edward syndrome.
Second question, which syndrome is strongly associated with absent nasal bone in first trimester?
Down syndrome.
Which investigation confirms fetal arrhythmia? If you don't know, we can move on to the next one. Which is the most common?
Echocardiogram.
Okay. Which is the most common skeletal dysplasia detected antenatally?
Lethal में achondroplasia and lethal में thanatophoric dysplasia and in non-lethal achondroplasia.
Okay. Best gestation age to perform NT scan?
11 to 13 plus 6, but best is 12 to 13 weeks.
Which Doppler is used to take decision for termination in absent end diastolic flow?
Umbilical artery Doppler.
Which genetic condition is associated with early onset asymmetric FGR? You have 30 seconds left.
Trisomy and triploidy.
Recurrence risk of neural tube defects without folic acid.
4%. Sixth answer is ductus venosus Doppler. After umbilical artery AEDF, we'll do DV Doppler.
Okay. Okay. So strawberry shaped skull, trisomy 18. Which syndrome associated with absent nasal bone? Trisomy 21. Investigation which confirms fetal arrhythmia, M mode USD.
They told fetal echo should be given or not? Full marks or half marks? Half. क्या बोला था? Echo half.
Most common skeletal dysplasia detected antenatally, achondroplasia. That is also okay. Best gestation age to perform anomaly scan 11 to 13 weeks. Doppler used to take a decision will be ductus venosus. We discussed it, Sir discussed it in his lecture initially. Then which genetic condition is associated with early onset asymmetric FGR is triploidy. And recurrence risk is 3 to 5%. Now, team B. Team B, please be ready. Which chromosomal abnormality is strongly linked with holoprosencephaly?
It's trisomy 18.
Which Doppler parameter predicts fetal anemia?
MCA peak systolic velocity.
Which one anomaly associated with non-visualization of stomach bubble?
Esophageal atresia.
Double bubble sign suggests
Duodenal atresia.
Commonest chromosomal anomaly associated with microcephaly.
It's cytomegalovirus infection.
Amniocentesis should be done after how many weeks?
It's after 11 weeks.
Which maternal antibodies are associated with fetal heart block?
Antiro-antila antibodies.
Okay. Which heart defect is most common in Turner syndrome? Okay, time up. So anybody from the audience would like to answer the last question? Yes, coarctation of aorta. So chromosomal abnormality strongly linked with holoprosencephaly is trisomy 13. Doppler parameter is MCA-PSV. Then the third one, associated with non-visualization of stomach bubble, esophageal atresia or CDH. Then double bubble sign, duodenal atresia. Chromosomal anomaly associated with microcephaly is 13 or 18. Amniocentesis done after 16 weeks. Okay, 11 weeks, it's too early. That way we can damage the fetus. It is done after 16 weeks. After 11 weeks, they do CVS. Then which maternal antibodies are associated with fetal heart block, anti-Rho, anti-La? Which heart defect is coarctation? Team C, please be ready. Okay. Most common cardiac anomaly in Down syndrome.
EV septal defect.
Cutoff cervical length predicting preterm birth.
Less than 2.5 centimeter.
In twin pregnancies, what is the earliest sign of chorionicity in USG?
Next question, ma'am.
Name the malformation with USG sign, banana sign.
Anencephaly.
Best test to rule out recent CMV infection when IgG and IgM both are positive.
Avidity test.
Which Doppler is first to become abnormal in early onset FGR?
Umbilical artery.
Which type of blood is used for intrauterine transfusion? Group and hematocrit.
O negative, CMV negative, irradiated, leukocyte depleted, gamma radiated.
Hematocrit? At which hematocrit?
Ma'am, it should be approximate 6 to 75%.
Most specific spinal defect related with uncontrolled diabetes.
Caudate venous.
You want to answer the third question? You have time.
Last question. Ma'am, which is
twin pregnancies, what is the earliest sign of chorionicity?
Twin peak sign.
Okay. Most common cardiac anomaly is AV canal defect. Cutoff cervical length is 25 mm. Twin pregnancies, this is lambda sign, T sign. Then banana sign is associated with Chiari-2 malformation. Then best test is IgG avidity testing. Then the Doppler first to become abnormal is umbilical artery Doppler. And hematocrit is 75 to 80%. Most specific defect is caudal regression syndrome. Team D. Question number 1. Which component of quadruple test are raised in Down syndrome?
Inhibin, beta HCG.
Which ratio is used to predict survival in CDH? Congenital cataract is seen in which congenital infection?
Rubella.
Best prenatal test to rule out hemoglobinopathies. Which common genetic condition is associated with echogenic bowel? You can name anyone.
Duodenal atresia.
Which invasive test can be done earliest in pregnancy?
Chorionic villus sampling. Chorionic villus sampling.
Which condition shows keyhole bladder on ultrasound?
Persistent posterior urethral wall.
Cutoff MCA PSV value for intervention in fetal anemia.
Greater than 1.5 MOM. 1.5 MOM.
Second and fourth question, if you want to attempt, there is no negative marking.
CPR ratio in the second. Cerebroplacental ratio.
Cardiac and thoracic ratio.
Fourth question, best prenatal test to rule out hemoglobinopathy.
amniocentesis.
No, which test do we order in the fluid?
Invasive testing amniocentesis.
The name of the test.
How do we detect the hemoglobin abnormality?
Amniocentesis.
Which DNA test you perform? That is what they're asking. Which DNA test you will perform after amniocentesis? Okay. Sir said that we should compensate you with another question.
How do we differentiate between CPAM and BPS on ultrasound?
Can you repeat the question?
How do we differentiate between CPAM and bronchopulmonary sequestration on ultrasound?
Pleural effusion.
How do we differentiate omphalocele and gastroschisis on ultrasound?
Paraumbilical defect, abdominal wall defects.
Okay, we'll give it to you. Then, which component of quadruple marker? The answer is HCG and inhibin A. Ratio, the CDH is OE LHR. Okay, so what you said was CPR ratio. It is done in IUGR.
Thoracic and cardiac circumference ratio.
Initially we said CPR ratio, so that was the wrong answer. Then congenital cataract is seen in rubella. Best prenatal test is beta chain sequencing. We perform DNA sequences of the beta chain of hemoglobin. So that is all we were expecting. So which common genetic condition is cystic fibrosis? Invasive, this was also discussed in the panel, cystic fibrosis associated with echogenic bowel. Then invasive testing would be CVS. Then keyhole bladder seen in posterior urethral valve, and cutoff is 1.5 MOM. So the result, the final marks are Team A 75 out of 80, Team B 40 out of 80, Team C 60, and Team D also 60. Second round, so there will be a case scenario. Each scenario you will be asked 2 questions. Okay, and you will be given, we'll give you 2 minutes time only, right? And you'll get +10 for each answer. If you're not able to answer, this question will be passed on to the next team. Okay? So we'll start with Team A. A 27-year-old primary patient at 31 weeks 4 days gestation presents for routine checkup. Her symphysiofundal height is 27 centimeters. Ultrasound shows effective fetal weight 2nd percentile. AC 2nd percentile. Uterine artery Doppler shows PI more than 95th centile and MCA PI is less than 5th centile. Ductus venosus Doppler is at 50th centile. Her uterine artery PI is 99th centile. So the first question is, explain the antenatal surveillance and delivery plan for this patient. And the second question is, enumerate at least 3 clinical conditions which can lead to this condition. There is a time limit.
Answer to first question is, we'll do 2 weekly Doppler for this patient and will plan termination at 37 weeks. Labor induction can be done in this patient. And answer for second question.
2 weekly what? Explain.
What will you do? How will you do the surveillance 2 weekly?
What do you want to see every 2 weeks?
Every 2 weekly umbilical artery Doppler and ductus venosus Doppler will be seen, and if any abnormality is there, then we'll defer. If the Doppler parameters are normal, then we'll deliver at 37 weeks. For second question, 3 clinical conditions for FGR: congenital heart disease, genetic abnormalities, maternal hypertension, diabetes mellitus.
Okay. Anything else you want to add? Okay. Okay, so what you said was correct, that you will do Doppler monitoring as well as you will do NST and growth scan every 2 weeks. Okay, so that is what one thing you missed was the growth scan and NST. And the 3 causes were correct. Team B, a 35-year-old Gravida 2 Para 1 Live 1 woman with hypothyroidism underwent NT scan at CRL corresponding to 13 weeks with the following findings: NT 1.1 mm, nasal bone present, uterine artery Doppler more than 95th centile, PAPE 0.1 mom, beta HCG 2.8 mom. Risk of trisomy 21 is 1:100. So what counseling should be done for this patient, and what intervention is prescribed at this time based on these reports? Give the details of advantages of why you are choosing this intervention. The risk of trisomy 21 is 1:100. So now what will you do with this patient?
First, we will confirm the diagnosis by doing the CVS, chorionic villus sampling and amniocentesis, and advantage of that, because it will give us a definitive diagnosis, because on the basis of uterine artery Doppler, it's more than 95 percentile, which is abnormal. It should be less than 95%. That means the placental resistance is more, so the baby will be growth restricted. Early FGR will be seen in this patient, and NT is 1.1, which is not a definitive diagnosis. So we have to confirm the definitive diagnosis by doing the CVS and amniocentesis, and it will give the definitive diagnosis, and we can plan the treatment based on that. And it's before the just first trimester is not completed, so we can plan for termination of pregnancy if our tests give a confirmative diagnosis.
Okay. Suppose she continues the pregnancy, do you want to prescribe anything based on these reports?
Yeah, I want to prescribe levothyroxine to the patient, and after
anything else based on these reports?
Uterine artery Doppler you mentioned.
Yeah, I'll advise the tablet aspirin 75 mg OD.
Okay.
Yeah, to prevent the preeclampsia development.
Yes, so the risk of preeclampsia was more in this patient since uterine artery Doppler is raised and PAPA is low, right? And risk of aneuploidy is high, so she should be offered invasive testing. And ecosprin will be offered 150 mg to reduce the risk of early onset FGR and preeclampsia. Okay? Now team C. A 26-year-old Gravida 2 Para 1 woman, blood group A negative, presents at 28 weeks with ICT report positive and a titer of 1:16. Ultrasound shows no high drops and MCA PSV is 1.5 mom. How will you monitor this patient? If MCA PSV rises to 1.7 mom at 30 weeks, how will you manage the pregnancy?
Ma'am, first of all, if MCA PSV is 1.5 mom, it shows that there is risk of severe anemia in this patient. So I would like to do first of all, cord blood sampling. If it shows hematocrit is less than 45%, I would like to prescribe intrauterine transfusion. and if MC is 1.7 mm, it defines that there is severe anemia in this patient. So at present she is 30 weeks. Now I would like to prescribe intrauterine transfusion or to maintain the hematocrit 45% around. First of all, I will maintain the hematocrit slightly higher because there is degradation for 1 gram percent daily. So I will maintain the hematocrit 45%, or I will do the subsequent transfusion as per my report of hematocrit up to 36 weeks.
So the diagnosis is alloimmunized pregnancy. Fetal monitoring should be done 1 to 2 weeks till it becomes above 1.5 MOM. After it is already 1.7 MOM, we will confirm the anemia with chordocentesis, measure hematocrit, hemoglobin levels, and then proceed for intrauterine transfusions. And repeat this Doppler 7 days post intrauterine transfusion. Okay. Team D. A lady presents at 16 weeks with ultrasound report showing twin gestation and T sign on her previous scan. How frequently will you monitor this patient? And name 3 complications specific to this type of twin pregnancy.
T sign is seen in monochorionic twins. Every 2 weekly monitoring has to be done. 3 complications in monochorionic twin, twin transfusion syndrome, twin anemia.
What will you monitor?
2 weekly. What are we trying to rule out? USG Doppler of middle cerebral artery. When do we start surveillance? Since 12 to 14 weeks, every 2 weekly. 2 weekly you want to see NCA doctor. What are we trying to rule out by doing 2 weekly?
Name the 3 complications first. Then you will be able to answer the first question.
Twin transfusion syndrome, twin anemia, polycythemia sequence, twin reversal arterial perfusion.
Yes, so with these, you want to look for these complications. So what will you see in this patient to find out whether these complications are occurring or not?
What is the aim of doing frequent surveillance? To see the blood flow in.
Okay. Okay, so from 16 weeks, monitoring should be started. If it is uncomplicated twins, are monitored with ultrasound scans every 2 weeks to rule out TTTS initially and then to see the growth. Detailed anomaly scan will be done at 18 to 20 weeks, and uncomplicated pregnancies are typically recommended for delivery between 36 to 37 weeks. And the complications are correct. Okay. So this round scores are Team A 8, Team B 7, Team C 8, and Team D 7. Now round 3, this will be a visual round. 2 image-based questions will be asked per team, and you will be given total 60 seconds to answer. 4 options are correct, okay? 1 correct answer will give you 10 marks. And this question can be passed also. We'll start with Team A. Which of the following conditions does not correspond with the ultrasound finding shown in the image? Edwards syndrome, CDH, Noonan syndrome, and Duchenne muscular dystrophy.
Option 4, Duchenne's muscular dystrophy.
Yes. Team A. At what atrial diameter of the lateral ventricle is fetal ventriculomegaly diagnosed on ultrasound? 8, 10, 12 or 15?
Option 2, more than equal to 10 mm.
Right. Team B. Which of the following chromosomal anomaly is associated with the ultrasound finding shown in the image? Edwards syndrome, Patau syndrome, Down syndrome, Prader-Willi syndrome.
Edwards syndrome.
It's double bubble sign. Duodenal atresia, you see double bubble sign, so it is commonly associated with Down syndrome. Then, at what AP diameter or fetal renal pelvis pylectasis is diagnosed on ultrasound? More than 4 before 28 weeks, more than 5 before 28 weeks, more than 6 before 28 weeks, or more than 3 before 28 weeks? They're asking before 28 weeks.
More than 5 before 28 week. More than 5. Option 2.
The answer is more than 4. Team C. Target ultrasound shows these findings. What is true among these? Dandy-Walker malformation, quadruple test will show raised AFP, alpha-fetoprotein. Specific marker for trisomy 18 and best visualized only after 28 weeks. Which statement is true for the deformity shown in the image?
Option A. Dandy-Walker malformation.
The answer is quadruple test with raised AFP. This is lemon sign and banana sign. It is associated with neural tube defects. Next question, okay? Which of the following statements regarding this condition is correct? You have to see the image, okay? Occurs due to failure of closure of posterior neuropore, usually associated with chromosomal abnormalities. Maternal AFP is decreased, and recurrence risk after one pregnancy is 3 to 5%.
Option D. Option D. 3 to 5%.
Correct. Okay. Can you name what this condition is?
Encephaly.
Team D? Question. What is true about the USG finding? Umbilical vessels are on the right side of the defect. It can be associated with aneuploidies. There is no membrane covering the defect. The liver and bowel float in the amniotic fluid. First, you have to identify what this defect is. Which of the statements is true? Time.
4. Option 4.
The answer is can be associated with aneuploidies.
What is this condition? Gastritis. Just now you answered. This is not paraumbilical defect. You can see the vessels over the bulge.
Next. Which of the following maternal or fetal condition is least likely to be associated with the findings shown in the image? sacrococcygeal teratoma, fetal tachyarrhythmias, fetal multicystic dysplastic kidneys, and twin reverse arterial perfusion.
Option 4.
Fetal multicystic dysplastic kidneys. Twin reverse arterial perfusion, one twin will definitely have hydrops in this. Okay, so the final scores are Team A 20, Team B 0 for this round, Team C 10, and Team D 0. Okay, so the next round is a buzzer round. So we'll be looking at all of you. You have to raise your hand. Whosoever raised their hand first will answer this question. Okay?
One person should raise so that we can see who has raised first. There is negative marking, so be careful.
If you answer incorrectly, you'll get -5. Okay? So please listen carefully. Question 1. What is the recommended folic acid dose preconceptionally for low-risk women?
400 microgram. 500 microgram.
What should we do?
Sorry,
We give
400
it.
microgram.
Okay. Okay. Next question. Polydactyly, polycystic kidneys, and encephalocele are components of which syndrome?
Trisomy 21.
Wrong. Anybody else wants to attempt? Audience? Meckel-Gruber syndrome. Most common mutation in cystic fibrosis. Okay. Okay. Posterior fossa cyst with cerebral vermis agenesis and elevated tentorium. Dandy-Walker malformation. First line management in monochorionic twins.
Endoscopic laser ablation.
We'll give it to both. Both of them answered simultaneously. Yes, we'll first identify who raised their hands and then you start saying. Okay. What does a reversed A wave in ductus venosus indicate in first trimester? Okay, we'll give it to you. Common arterial trunk, cleft lip and palate. Hypocalcemia, immune deficiency are components of which syndrome? Okay, Team C gets it. Okay, best test to detect microdeletions and duplications. Okay. Team, question number 10.
Fetal ascites. C.
You're right. You just have to frame it properly. Megacystic. Yeah, right. Okay. This is for the audience. This is not for you. This is for the audience. Anybody from the audience wants to answer?
ये वाला हाँ abstinence.
Yes. Okay. So for this round, Team A 30, Team B 5, Team C 50, and Team D 0. Team B 52 marks. Team C 128 marks. And Team D 67 marks.
Whatever are the marks, well played, and God bless you. और बहुत अच्छा लगा सब इन साथ आके. So we will distribute the prize, and I request Dr. Manikandan to Ashita.
First of all, congrats to the quiz master and the scorer. My God, excellent quiz.
Yes. Thank you, Avantika and Ashita.
With the first places, Dr. Sushmita and Dr. Ankita from AIIMS Bhopal. Second is Dr. Vidhi and Dr. Rishu from NSCB Jabalpur. And Dr. Ranjana from NSCB Jabalpur. And Dr. Seema and Dr. Pratibha. Please come on the stage.
स्क्रीनिंग वाले भी आएंगे. And Ashita, it is a very difficult task, Avantika, I understand, to make questions for very difficult and unambiguous answers also. So I am very thankful to you that you joined from AIIMS Bhopal, and very nicely conducted quiz with Ashita. Thank you very much. And now I request Devashish to, why I called him, because he is a consultant in radiology department. And the gynec department, they are sending cases to him for his special opinion, final opinion. So I asked him, please discuss few cases which he handles or give his final opinion for management. So I request Devashish to come and deliver his lecture.
This will be the last, but I think not the least lecture. So I start with the case-based discussion in my routine practice. So I start with the first case. Here, this case was referred to me for the target scan, where I find, just a second, where I find the anossified nasal bone. Apart from that, the nuchal fold thickness is also increased. I try to take the 3D image of the face to demonstrate if any other abnormality was there or not with the face, or some typical facies are associated with this finding. So maternal age was also advanced, that was 35 years. So I started looking at the fetal brain, and after looking at the fetal brain, I was pretty sure that it must be Down syndrome only. So I advised her to go for the amniocentesis, and which came positive for the Downs. So why looking at the brain, I was so confident that this should come out to be a Downs, because few years back, like 1 or 2 years back, the 21st World Congress of the Fetal Medicine, FMF UK, has demonstrated the seagull sign with the thin subplate. And in the recent journal of the American Journal of Obs and Gynae, this is a pretty good journal, pretty good article, where you can see the normal brain. In this normal brain, there are layers, multiple layers. The outermost is the cortical plate, below which lies the subplate, and below which the hyperechoic layer is the intermediate zone, and below which is the subventricular zone. So this is a normal brain where the cortical that is the subplate and the intermediate zone are almost of equal length, or the subplate is little bit more in thickness than the intermediate zone. So they have taken few ratios of that. The basic crux is that the subplate should not be less in thickness than the intermediate zone. So this is a fetus brain of a Down syndrome baby, where you can see the subplate is thinned out, leading to the seagull sign. So this was there with my case. You can see the hypoechoic layer, the subplate, which is thinned out as compared to the intermediate zone. So, and I also took the measurements for that, and that came out to be 4.5 and 3.5. So the subplate was definitely thinned out. So this was the case of Down syndrome. Now move on to the second case, where this was also referred to me for the target scan, and I found that the polyhydramnios is there. The long bones are shortened and quite deformed, also little bit of bowing, and the epiphyseal ends are also appear deformed. When you look at the brain, the cortical plate of the brain is thickened and irregular, and the subarachnoid spaces are also enlarged. Also, the lateral ventricles appear little bit prominent. Corpus callosum was surprisingly normal, and the brain stem, little bit of the brain stem was also visible, which appeared to me was normal. So I made a diagnosis of diffuse polymicrogyria with prominent subarachnoid spaces, and my differential diagnosis was the tubulinopathy, Walker-Bauwach syndrome, and the infections. But Walker-Bauwach syndrome has the brain stem which is deformed, jet-shaped, so which I don't find it. The tubulinopathy, because I was suspecting the polymicrogyria. So I did the amniocentesis of that patient, and it was a surprise to me that it was in fact L1-CAM mutation. And apart from that, it also came positive for KIF1A gene, which is a autosomal dominant gene. Now skeletal dysplasias like shortened long bones are not associated with L1-CAM, while KIF1 mutation are associated with shortened long bones. So this was a combination. So I advise parents to go for the parental segregation, and both the parents undergo whole exome sequencing. So the mother of the patient, mother came carrier for the L1-CAM mutation, while there were other genes were also there for which the mother was carrier. However, the KIF1 gene, which was autosomal dominant in the fetus, the mother also carried the same gene and is still not presenting with the disease. So how is this possible? So there are few explanations for that, that how a dominant allele can appear to become recessive, and that is a mutation that can occur in the DNA, become the non-functional or less functional, that is a loss of functional mutation can appear and become recessive in the mother, and that can be carried forward to the fetus and become dominant. Or there can be reciprocal relationship also. So that was the explanation for this case, but it is a very rare kind of mutation where you find both the abnormal genes presenting with the expressing their phenotype in the fetus, leading to different expressions in the brain as well as in the long bones. For the third case, this was referred to me for the fetal echo, where they were finding the reduced heart rate, continuously reduced heart rate. The heart rate was around the 70 to 80 beats per minute. So the heart was structurally, everything was normal in the heart. Though you can find all the 4-chamber view, LVOT, RVOT, 3-vessel tracheal, everything was normal. I took the atrial heart rate, which was 69 beats per minute, and it was reduced, but the beat-to-beat variation was normal. There was no rhythmic abnormality. I took the ventricular heart rate, which was also 61, and the ventricular heart rate was also rhythmic. There was no rhythm abnormality with this. I took the PR interval. The PR interval was significantly increased. It is 536 millisecond. Actually, it should be around 90 to 150 milliseconds PR interval in normal fetus. So it was definitely a case of sinus bradycardia with first degree heart block. So aortic rhythm was also normal, pulmonary rhythm was also normal, and the heart rate range was around 60, 70, 80, like that only. So I suggested to go for the ECG testing of both the parents to rule out the long QT syndrome, because the long QT sometimes is genetical. So if one parent is having the long QT syndrome, the fetus may be inheriting the long QT syndrome. Otherwise, the gene sequencing is the definitive method of for assessing the Down syndrome. I also advise for the indirect Coombs test to look for any infection or any immune complex mediated disease, and the maternal anti-SSA Rho antibody titer, which came out positive in this case. So this was definitely a case of the SLE or anti-SSA antibody. So what I wanted to tell you about this is that how to approach a case of fetal bradycardia. So first you need to understand to look for the normal fetal heart. If the heart is structurally normal or abnormal. If the heart is structurally abnormal, it is a whole new world now. Now the heart you have to assess for the fetal heart, and for that we do the fetal echo. If the heart is structurally normal, then you have to assess for the rhythm, that is it is normal or abnormal. If the rhythm is normal, that is 1:1 conduction is there, then the cause are very limited. Either the mother is going for some medications, or there are some infections, or antibodies like anti-SSA, ROLA antibodies, and the long QT syndrome. If the rhythm is abnormal, then the most common cause is the premature atrial contractions, and that is a self-limiting condition. Other causes are second degree and third degree heart blocks, other thing. So to manage these cases, we have to first know the cause. If the cause like the antibodies are there positive, then the hydroxychloroquine, dexamethasone, and IVICs are the treatment of choices. If mother is on any medications, then you have to stop, obviously you have to stop those medications. And for long QT syndrome, a long follow-up is required. For my last case, the case 4, this 25-year female presented to me in medical college with Gravida 4, Para 2, Live 1, Abortion 1 and Died 1 with prior 1 LSCS, and the gestation age in present pregnancy is 28 weeks, 4 days. You can see in this, the placenta is, there is complete placenta previa with mass-like formation with multiple irregular lacunae, and the interface between the urinary bladder and the uterus is, placenta is lost. On color Doppler also, you can see there are multiple abnormal vessels which are running from the outer surface of the placenta and running up to the posterior wall of the urinary bladder, showing arterial blood flow. So this was definitely a case of placenta accreta spectrum disorder. So why I wanted to tell you about the placenta accreta spectrum disorder, because this entity can be very well diagnosed on ultrasound. So MRI is actually a problem solving tool with the placenta accreta spectrum disorder, where the placenta lies posteriorly when you cannot assess the placenta properly. However, ultrasound is the first and foremost modality to diagnose the placenta accreta. Other multidisciplinary approach are also required. In other cases also, we need support from the radiologists, maternal fetal medicine experts, obstetrician, genetics, and pediatric surgery, and not but least the neonatologist, to manage these cases and do appropriate plan of the management. Thank you.
Thank you, Devashish, for, he has a lot of other cases also. He restricted himself for 4 cases, but when I talk with him and chat with him, he had a lot of interesting cases. Later on, we will have your more experiences, and this is a wonderful case. Thanks for your presentation. And at the end, have you felicitate the, huh? रह गया था. Devashish, please come here. Sorry. Faculty gift was, तुम थे नहीं उस समय. आ जाओ, दे दो. We will have this bumper draw, and there are rules. Rules मैं एक बार फिर से पढ़ देता हूँ. The rules of getting the bumper prize is that valid registration must only for practicing OBGYN, radiologists and pediatricians, not pursuing postgraduates. They already got the money for quiz. अच्छे पैसे मिले उन लोगों को. Put your name chit in a glass bottle at the time of registration between 9 a.m. to 10 a.m. Glass bottle will be taken away at 10:30 a.m. Already taken away in front of me now. Persons should be present at the time of lucky draw result and should have attended all the sessions. In cases of absence, second chit will win. In absence of third chit will win, and so on. So I am calling, madam, आप आइए, आप करा दीजिए इस बार. आप जीते थे. आपका भी नाम निकल सकता है. आपका रहेगा. मनी को बुला ले. मनी, प्लीज. हाँ, शी इज ऑल्सो ए कंटेस्टेंट. हाँ, you are a star contestant. This is the box.
Okay, I saw this box while registering, but I didn't put my.
No. अरे देवेन, इधर आओ. हाँ. No, because glass bottle, very less tickets, so we make the bottle small. तुम वो bumper ड्रा ले आओ. He is Deven and Nitin, हमारी टीम है. और बच्चे सब आए हैं and everyone is working very hard. So this is bumper prize and this is Galaxy A17 5G mobile phone of worth rupees 24,000. Previously we were not going for mobile, but because of my secretary, the gift has changed to the mobile phone.
They know what strikes the chord.
Yes. So I request you, please go ahead with the draw. And if you want to ताश जैसा करना है वैसा भी कर सकते हैं. हाँ, it card.
No, it should give a fair chance.
Yes, yes, yes. Sulekha Devani. Is she present here?
That's what you say, you miss the mobile.
You shuffle it again, yes. Dr. Rupa Sarkar. बहुत बहुत बधाई.
When they made the phone, your name was written on it.
So, I request Dr. Manikandan Krishnan to do a case. Deven, इनका file दिखा जरा. I have a very difficult case, and I asked Samsung people to keep their machine because they are keeping their machine. So I put a demo also. Every year I put a demo by the guest speaker, and most of the time we put some difficult case. So it is third intrauterine death, 5th month. Don't know why. No DNA preservation, nothing. No ultrasound report, nothing.
It's worse with each pregnancy.
4th, 5th, 6th IUD. DNC done. Blood group कराया तो था. मजा आ जाएगा if I don't do the blood group. But अपन ने इसका husband wife का karyotype नहीं कराया. वो छूट गया. कराना है.
Okay, the CMA is normal, so we can leave that. Syphilis negative.
Seronegative, basic, all investigations are normal.
Okay, still parental KT we can
Should
do.
be done.
That can explain something.
प्रांशु नमस्कार, ये डॉक्टर साहब हैं.
The audience.
See the basic, if it is possible, first 20+2 scan and the color Doppler of 3 vessels.
All right, so I'll go as per the protocol that we follow in the fetal clinic, which will be at a little bit more than your 20+2.
Okay.
Is that okay? Yeah.
Okay. And we, looking at the history, while doing the scan, what extra you want to see, please explain us also what you. एक mic और दे दो.
So the history is repeated intrauterine fetal demises with no other clue. We have looked at the RH status, she is RH positive, and in none of the previous pregnancies we have a documented evidence of a fetal anomaly or hydrops, and the charts were not available for review, so we are not sure. In this pregnancy, the fetus is chromosomally normal. The CMA has returned normal, so that's very reassuring. And let's just do a screening and then we'll see what happens.
Yes, I will do. I will do. You just color mic.
Hello. Too much. I want dual. So in this case, I would like to certainly we should do a transvaginal and see the internal os. It looks a bit suspicious. So we take the placenta. The placenta is good. This is what I said when I told about the placenta. It should be nice, long, granular, and have a good tapering margins. Okay, then we understand the placenta. Then in my practice, I do the maximum vertical pocket. Once that is over, I go to a free loop of cord. Generally, I prefer not to put the Doppler directly on the fetal heart for a heart rate. Heart rate. Then I start a head-to-toe examination or a toe-to-head examination, depending on how the baby is oriented in that particular case. In this case, perhaps head-to-toe. So go to the top of the head, from there keep coming down. What you see is the CSP at vergae, the lateral ventricles, transventricular plane. I prefer the transthalamic plane for the biparietal diameter. I take outer to outer, and generally I don't take the HC, but we take the OFD. And once that is done, then I go and document the CSP. When documenting the CSP, I remove the speckle reduction and the cross beam so that you can see the two leaves of the CSP clearly. So all CSP should have 4 leaves. Then you are sure that it is the CSP. Then once you see the CSP, go down on the fetus. That's the fornix. You can see the fornix here. This is not imaging the fornix, but at the level of the fornix, you can see the nice.
Does this image making granular helps you?
I like it granular in certain situations.
Okay.
Too much makeup, wrong information. Okay. And then we see the nice lateral sulcus. You correlate it with the gestational age. Then we move to the posterior aspect, get the CSP and then do, and then let's say, so I made and both lateral ventricles. No need to measure if you are quite experienced, otherwise it's a good idea to measure opposite the parieto-occipital sulcus, vertical, perpendicular to the ventricle plane. It's only 7.8, very normal, 8.5 normal. Then we go to the posterior fossa. So while coming to the posterior fossa, I had subtly tilted the probe, rocked it so that the midline echo is now a little bit like a seesaw, and the cerebellum comes on the top of the seesaw. So now it's not horizontal midline echo. Then you go and measure the TCD. Okay, it's already assist is there. Then we go and measure the nuchal fold, and both are okay. A slight increase in the nuchal fold, but it's a breech presentation. So when it comes cephalic, it will reduce a little bit. Then from there I come down. Now I go to the face. The first thing we get is the axial view of the orbits. I like a lateral insunation. You can also do a frontal insunation. Yeah, okay. So free should lead to cine, then only. So you can see that the eyes are okay. Then go down. From the orbits, if you go down, the next landmark is an axial view, which shows the posterior palatine line. So that's the posterior palatine line, the integrity of which tells us that the bony palate is intact. That's not measurement, that's just to show you. Then the probe is rotated to get the intact vermilion line of the nose-mouth view. Once you see the intact vermilion line, then your anterior closure of good. We don't have to worry more, but there is a legacy view that we take. That's called as the pre-maxillary bony triangle. So that's the pre-maxillary bony triangle. A triangular, the one. Top one is the fusion of the nasal bones. These are the frontal process of the maxilla, and this is the alveolar ridge. So the pre-maxillary triangle is done. Then again rotation of the probe, and then you will get the profile view. So profile view, profile view, profile view. Yes, very good. No, we don't want both. So if you take the correct profile view, baby, can I say? Okay, so when you take the profile view carefully, you should take it such that the baby looks at the opposite edge of the screen. Now you can do several things. You can see the nasal bone, you can see the superimposed sign of the palate and the vomer. This is the palate, this is the vomer bone, so both you can see. The chin should be a dot, and you can see the corpus callosum. So many things you can get it if you get the, and this is the echogenic fox. So many things you can get it with that one view, provided you are in the correct plane. Then we go to a screening view of the pinna. So you can see the pinna there. So you can see both pinna nicely brought out, pinna, and then that is the other pinna. It's not measurement, I am just using them as a marker. So the head and face over, now I come to the neck. And in the neck, there's a nuchal cord around the neck. Doesn't worry me at all. Even in term babies, it doesn't worry me. I don't report it at all. I trust my obstetricians to do the monitoring. So the neck is imaged axially to show that there is no mass or fluid collection. Then I go down. Of course, before going to the chest, I can finish the upper limbs. So whenever I look at the bones, I switch off all the decorations and makeup, not required. So that's the scapula, that's the so I do simultaneous corresponding segments. It gives me more confidence. Yeah, do it for, yeah, go. Yeah, hold on. So every time you take, you start from the body and then you go. And keep them horizontal, keep them with a little bit of fluid around, then it's all good. Yes, hold on. Then go to the last segment. When you go to the last segment, you zoom it up. You don't want unzoomed, we want details. So thumb, then fingers, and all the phalanges you should see. So don't stop when you just see the one phalanx or the palm. You should see all phalanx. So in my protocol, the fellows will actually do a clip rather than an image for hands. So in that way, I tell them to do this clip. So you will get everything when you view them back. Oops, sorry. All right, so we have open hands documented with all fingers and phalanges, and it looks normal. So now we will go to the thorax.
Fetal heart?
Yeah. Let's go to fetal heart. The variation is okay. Scan area should be even less. So we need to achieve a good frame rate. That is the most important thing in the setting for fetal heart. And you can see, hold on one second. And you can, I use the W10 millet. So I'm well versed with it. So you need to know this number here. Is the whole screen projected?
Yes.
Yeah. So this number should be 60 or above for a good reproduction of the fetal heart cycles. Okay, 30 is minimum. So you decrease the scanning area, you decrease the window so that that is there. And as we want fetal heart, the baby will never show it. So we go back to the second trimester setting. Now it's trying to show little bit of the backbone. So we will switch our mindset to a non-cardiac mindset. Go nicely behind. We can now see axial view of the fetal kidneys. That's the axial view of the fetal kidney. Push. All right. So we got the axial view. Do a sad spine. So they are like nearby only. So when you do a sad spine, again it's a bone.
First time I am seeing somebody making the image.
Yeah. So if you do with this, you can see that the bones, they tend to be flayed out, and they may get falsely fused. You can see that. That's not required. We want the truth, not beauty. As an imaging person, we should become familiar with a little bit of, If you can know which is the signal and which is the noise, then no need to do a lot of extrapolations. The lumbosacral spine, very important, the skin above the spine. Yeah. For very the bone will light up in it. We are looking at the bone. One practical tip is don't cut the spine. You didn't get a sliver, at least a fluid behind the spine. So that's what I was waiting for. Now I can say that the spine is all right. A fluid, sliver of fluid. Like should be there just behind the skin. A little bit at least should be there. Then only you should be okay to pass off the spine. Yes? And whenever there is, you can put the color from that. Now we have come to that. Now we'll come back to the heart later. Oh, okay. Then we can quickly, let me just quickly see for her sake.
टिश्यू पेपर दे रही उसको. Thanks a lot for attending this session. We conclude this session and
Those who attended this program, thank you Ideal Infertility staff, thank you Hotel Jackson and all staff for arranging all the arrangements. Thank you Samsung. Thank you Samsung who provide their machines for this. Thanks to all. Thank you for coming. For all the arrangements. Thank you.
okay, bye bye.
जी मैम थोड़ा सा क्लोज आइए. यस चलिए.